Good evening. So thank you. I see some people waving. Thank you for joining us at the highlight reel version 10. Isn't that great? So this has been so successful that we're version 10. So let's give it up right there and get it off to a good start. I hope you had a very, very successful Energy Semi-Annual Conference. And obviously, my name is Brad Monk, and it's my pleasure to be here.
Before we get started, I want to share the GOG Foundation's mission and vision. I'm Dr. Tom Herzog, and before we get to that, I want to tell you what we're doing tonight, and that is we're going to share the content from the recent meetings from this fall 2025 and try to give you the latest of what's going on in GYN oncology. Dr. Monk and I are pleased to serve as your moderators, and again, getting back to our mission and vision, as an organization, we updated our mission to align with the work we're doing in education. As new approvals and therapeutic agents become available, it's more important than ever for us to keep you informed as an organization. We're fulfilling our responsibility by sharing these critical updates. Brad?
Yeah, so let's get started. Our goal is to share key data. We want to be data-driven. We are going to be fair and balanced. So I want you to understand the past, the current situation, and anticipate the future. I want you to take a moment here. This is a pre-test to scan this QR code. It will also help us keep the content fresh and engaging for future events. So I think this is a pretty handsome group. So thank you for being here. I'd like to thank Rob, Ramesh, Katie, Dave, Bob, Leslie, Brian, and our invited speakers, Emmy Zeros and Rachel Grisham. Thank you for your commitment to the GOG Foundation, not only for today, but every day. A huge thank you to all of you attending tonight and to our entire roster of investigators for the efforts that we help in transforming the standard of care. And I'd like to thank Jenna Cummins and her staff, Katie Campbell and her staff, for not only being here, but what you guys do for us every day.
Thank you, Brad. I also want to express my sincere gratitude to our GOG sites, global partners, and collaborators for your continued dedication. Special thank you to Dr. Bhavna Pathori and Dr. Ramaz Iskander for thoughtfully developing tonight's agenda. I know how much work's gone into that, so thank you. For this evening's highlight reel, we'll be exploring data presented at recent GYN oncology meetings and sharing insights on emerging research, new data presentations, and the drug approvals that continue to move our field forward. The overall objective for this session is to showcase clinical trials and other newsworthy content and education from major medical meetings throughout the year. Additional objectives are listed here on the slide. Our expert panelists will engage through dynamic discussions, analyzing emerging approved therapies and investigational agents, sharing insights and context into current as well as future advancements. The GOG Foundation is proud to be an ACCME accreditor provider. This is an accredited program, and we go through a rigorous process to review, edit, delete, and modify any content that may not follow ACCME guidelines. In compliance with ACCME regulations, the GOG Foundation, as the accredited provider of this activity, must ensure that anyone who's in a position to control content of the educational activity has disclosed all relevant financial relationships with any commercial interest. Designated officials review the content presented and manage all reported conflicts to ensure a bias-free presentation. Faculty disclosures are detailed on this slide as well as on the next slide. Note that some of the presentations and discussions today may include off-label use of products or devices. All content shared tonight includes permissions and details that are in the public domain. This program is accredited, allowing you up to 2.5 hours for CME. For those of you wanting to claim CME credit for this course, you will need to complete the post-meeting survey, which we will email to you after tonight's session. Brad, back to you.
Yeah, I'd like to thank our supporters for independent medical education support. AbbVie, AstraZeneca, BioNTech, Corcept Therapeutics, Eisai, GSK, Karyopharm Therapeutics, Merck, Natera, and Verastem. I'd also like to thank the sponsors, Gilead and Faith Therapeutics. If you're here in the room, there's an open bar in the back, and this is very independent. They had no input into the discussion. It also helps support, and I want to recognize our AV team for being with us tonight. Thank you.
Okay, let's get started. Here's another quick look at our agenda. To stay on schedule, Dr. Monk and I will be enforcing the time limitations for our presentation. What are we doing, Brad? Are we using electricity tonight or fire, or what are we doing?
So I prefer projectiles.
Okay.
I don't like to kill people, but
All right, sounds good.
O'Malley's a big target, and he's my closest guy.
There you go. I invite our audience to engage and participate during this session by using the microphones in the room. We will now begin. Brad, you want to do this?
Yeah, go ahead.
We will now begin this evening's session, kicking off with part one, ovarian cancer, new therapeutic opportunities and novel drugs under investigation.
So if you haven't heard, there's this study called B96. Maybe you've heard of it, but it was presented at ESMO. And so there's some new information. I'd like to introduce the USPI for that study. Thank you. Dr. Zeros from Roswell Park. So let's kick it off. Excited to hear you. Thanks.
Thank you. I'm honored to be here tonight, and thank you for the GOG to inviting me to present the data. They give me exactly 5 minutes, so hopefully I won't get projected out of this seat. So we're going to review the Keynote B96 data, which was presented at ESMO, and this slide deck represents the most updated clinical efficacy and safety data. So the clinical trial was asking the question whether adding pembrolizumab to the already well-known backbone of weekly paclitaxel and plus or minus bevacizumab could enhance the survival in patients with recurrent ovarian cancer. So Keynote B96 was a large, global, randomized phase 3 clinical trial that allowed patients to enroll with 1 or 2 prior lines of treatment, and they had to be platinum resistant. There were no platinum refractory patients who enrolled on this clinical trial. Prior anti-PD-1 bevacizumab and PARP inhibitor was allowed before coming on the clinical trial. The primary key endpoint was progression-free survival, and the key secondary endpoint was overall survival. The patients on the clinical trial were randomized receiving pembrolizumab or placebo, plus weekly paclitaxel, which was 80 milligram per meter square, day 1, 8, and 15 on a 21-day cycle schedule. So there was no break, as a reminder. And the bevacizumab was given 10 milligram per kilogram every 2 weeks. There was stratification already planned in the clinical trial, planned bevacizumab use, region of the patient, and PD-L1 status measured by CPS. So here is the baseline characteristics of the patient that enrolled on Keynote B96 trial. As you can see, most of the patient had 2 prior lines of treatment and had a really short platinum-free interval. So 50% of them had less than 3 months of platinum-free interval. Approximately half of the patient already had seen bevacizumab coming on the clinical trial, and 73% of these patients ended up receiving bevacizumab on the trial. The choice of bevacizumab or giving bevacizumab was up to the investigator, and it was provided on the clinical trial. As you can see that they were typically your recurrent high-grade serous ovarian cancer patient who had early relapse after last platinum treatment. So clinically a very challenging cohort of patients. So this is the progression-free survival on the clinical trial in the CPS 1 or greater than 1 cohort and the intent to treat patient population. You can see that the progression-free survival curves separate over time, and then you can see that both of these cohorts had a clinically significant and statistically meaningful overall survival benefit. The pembrolizumab arm had 8.3 months versus 7.2 months in the placebo arm, in the CPS greater than 1 or 1 cohort, and the ITT patient population was 8.3 months versus 6.4. It's important to note that the separation of the survival curves were durable over time and they did not come together, which really tells us that the biology that's driving the separation is real. Here's the overall survival data from the PD-L1 positive cohort. You can see that the pembrolizumab arm had a median overall survival of 18.2 months versus 14 months in the placebo arm. This was, again, statistically significant and clinically meaningful, more than 4 months gain in overall survival. The hazard ratio was 0.76. Again, as you can see that the separation was durable throughout the clinical trial. And this is the first phase 3 randomized trial that showed IO benefit and overall survival benefit in a platinum-resistant recurrent ovarian cancer patient population. This is the summary of the toxicities, which were very much expected from the weekly paclitaxel administration. There was nothing new, that was all manageable. And immune-related adverse events were also seen in the arm that received pembrolizumab, but it did not limit the dose administration of the paclitaxel. So overall, this is a really familiar regimen that we often use in clinical setting. And the treatment discontinuation of 1 or 2 of the agents were allowed on the clinical trial if the patient was not tolerating the regimen. So overall, again, this was the first phase 3 randomized trial that showed IO overall survival benefit. And I'm ready for further discussions on this clinical trial. Thank you.
So Dave, before you kick it off, and you're going to talk a lot about the future, I just want to, because I want this to be a little conversational, and we're all friends here, and everybody wants to know the question that I'm going to ask you. So I can't count all the negative IO studies in ovarian cancer. I probably could, but I'd need both hands. Why is this the exception, the one study, if you will, that has an overall survival advantage? I'm going to ask Emmy, and then, yeah.
Is the microphone turned on?
Yep.
So I think this is the million-dollar question that everyone is asking. Why is this study different than other studies? And I think we were also surprised to find out that this was positive. But looking back, I think this was a really, really smart design. Number one, weekly paclitaxel has been shown to be the most immunogenic chemotherapy backbone. So it really enhances antigen presentation and decreases the myeloid suppressor patient population. So I think the weekly paclitaxel chemotherapy backbone really made a difference. On the top of that, this was an anti-PD-1 blockade as opposed to anti-PD-L1, which was used in all prior clinical trials that were like large randomized phase 3 clinical trials in ovarian cancer. And I suspect that the PD-1 blockade also mattered in a disease where there's less immunogenicity and more genetically stable. So probably using the anti-PD-1 also made a difference. It also really had a homogeneous comparator arm, the weekly paclitaxel plus or minus bevacizumab. So there was no question about other chemotherapeutic agents that could have created more heterogeneity.
Great. Great question, great answer. Dave, let's kick it off. Let's ask some questions about this, try to put this in context.
Three overall survival benefits.
That's right.
And we just heard from Rosella, press release, was that yesterday or was it the day before? It just is running together.
That's right.
Energy is running together. Then the last 2 days, press release that Rosella hit statistical significance on overall survival. Mm-hmm. So we have overall survival benefit. Yes.
That's right.
Katie Moore started us off with MERV, first trial ever in platinum-resistant overall survival.
Let's go.
Followed by now B96, which officially hit overall survival, and now Rosella. What are we going to do? What are we going to do? In my mind, weekly paclitaxel, I saved it when I needed a win, right? When I needed a win, started getting ascites, symptomatic, weekly paclitaxel plus minus Bev, usually Bev. You guys know me and Bev, right? Okay? So how are you going to sequence this? I mean, we shouldn't be waiting to use weekly paclitaxel, weekly taxanes. But we also have a biomarker that's 1/3 of our patients, high folate receptor alpha. Rob, what are you going to do? How are you going to sequence this? You didn't know I was going to call on you there, did you? Wake up, buddy.
Actually, I figured you'd pick on me. So what are we going to do is a good question. I think I'd be interested to hear what the audience does when you have a biomarker-directed therapy like mirvetuximab, and then 2 weekly paclitaxel studies that we are familiar with. And I think that because the eligibilities are slightly different, and if we're going to stick close to to where the trial alignment is, the B96 trial only allowed up to 2 priors because of the bevacizumab association. We have a little bit more flexibility with the others. So, and I think that people will vote with what they're comfortable with. But I think that they're all a win.
That was a really wimpy question. Rachel, come on, give us the real answer. Give us the real answer here.
Is that most of my patients are going to get all 3 because our patient, and they're going to live longer. It's all going to pile up.
So you're going to give, if you're going to nab paclitaxel.
Sequentially, not all at once.
Well, now that's a question. Would you sequence after B96? Would you go to Rosella regimen?
Yeah, they're different.
So you think the nab-paclitaxel is different than the weekly paclitaxel?
If you're going to relacorilant with it, yes, I do.
Interesting.
I do, and I think that there's going to be so many opportunities, and the individual sequencing is going to depend on the individual patient, of course, and the factor. Each patient is different, and we use those factors to decide what order to give the treatments in. But I think there's going to be room to give all of these active regimens to most of our patients.
Ramez, Leslie, then back to Rob. Then we'll move on.
A brief statement, which is, I don't feel burdened by this data. I feel blessed by this data. Because exactly what was alluded to, which is we need opportunities for our patients. I don't feel burdened by the fact that I'm going to have to rationalize. We do this all the time using approved drugs in sequential manners in a way that makes clinical sense independent of clinical trials that are available. So congratulations to the teams that did these trials, and we have opportunities.
I think it was Bhavna, right?
And you thought my answer was wimpy.
Great. It's great to have options, right? As many as possible. Rachel, I love that you said that you would give the 2 taxanes in a weekly fashion, even after frontline carboplatin taxane. I've been struggling with that, and so my question for Emmy is, she has this cyclophosphamide data with Bev-Pembro, and do you think that immunogenicity is the same, as you just said, that the weekly taxanes? But before I let you answer that, just, mirvetuximab is still restricted. It's still biomarker restricted, which we haven't brought that up just as of yet. And I think that it's going to move into an earlier line of therapy. So I think that MIRV might fall out of this space. So then we'll be left with these 2 excellent weekly Taxol backbone options. But can Emmy answer my question?
Emmy,
really quick?
respond, and then Rob, and then we'll move on.
I think we're talking about 2 different checkpoint blockade regimens in the recurrent ovarian cancer setting. So one is the Keynote B96 data, which is highly effective in patients who have a large disease burden, and you would like to get a disease control in a very timely fashion. And we have another regimen on the NCCN guideline, which Leslie was alluding to, which is pembrolizumab combined with bevacizumab and oral Cytoxan. So I think about these 2 regimens as 2 very complementary regimens. The oral Cytoxan combination is typically better for patients who have less disease burden, more stable disease. Extremely works well for patients who have lymph node predominant disease, where I'm looking to achieve durability and survival benefit, and less inclined to focus on shaving off the disease by giving a really active chemotherapy in a weekly fashion. So I think these regimens are very complementary. It just really depends on the biology and the disease burden the patient has.
Quickly,
Yeah.
Rob.
So I think ultimately this is going to get back to what patients have been on before in the sequencing. So this is a moving landscape. So as the drugs get moving into different parts, what they've had before, how they've tolerated, all those are going to go into decision making. But one thing I wanted to point out in B96 is it allowed weekly paclitaxel in the front line. And they could still go on trial with weekly paclitaxel recurrence. So getting to Rachel's comment.
We want to stay on time here, but the B96 2 priors. And
Up to 2.
Is that because of potential T-cell exhaustion? 45% of the Rosella patients had 3 priors. And to your point, Rob, or whoever, let's let someone else answer it, Katie Moore, does the label matter? Because greater than 40% of the patients in Rosella had 3 priors, which was not eligible for B96.
Right.
Katie, what do you think? Katie
Exactly.
Moore.
What do I think of
the number of lines of therapy doesn't matter because B96 is 1 or 2 lines, and Rosella, 45% of the patients had 3 lines. In other words, if you see a 3rd line, this is relevant because of Mirasol, we sort of don't necessarily pay attention to 3 priors, but are we going to pay attention to the number of priors here?
Well, I mean, we could sort of make a false story around this, that, well, a potentially false story around this, that B96, because it was 1 to 2 priors, when they became resistant, they're more sick, and so they're different than Rosella and Mirasol, that, you know, roughly half of the patients came on as their 4th line of therapy, and so they got resistant later. But you don't really know that. You don't really know that the patients who came on Mirasol hadn't had 2 prior lines in the platinum-resistant setting. And so I don't think we can really make that jump to qualifying the resistantness of the 2 populations, and for me. And so I think at this point, consider these all options in the platinum-resistant space, and to everyone else's comments, would base it on prior therapies and what patients want. I mean, a lot of patients don't want weekly therapy. And so I think it's going to be an evolving landscape in terms of sequencing and selection and safety for patients that has to take a lot of things into account. So I don't know that I would make a big deal out of 2 versus 3, personally.
Yeah, and we don't know some of these nuances in terms of the differences in lines of therapy. There's other nuances and differences between the trials that we had up there, and that's why it's so important that you have to be very careful in terms of cross-trial comparisons. These subtle differences can really change things dramatically. We've seen it before.
Okay.
But we've seen consistently in the weekly taxanes, I'm going to say weekly taxanes, without Bev, 30% plus or minus 5% across multiple trials. 40% plus 42.3% on MERV, right? And we saw, and people have asked me, well, on B96, the weekly taxane plus Bev underperformed, but remember only 73% of people had Bev. So you're between that 40 to 55% that we saw in Aurelia. So you kind of have that split difference. So remember that it's 55% with Bev, it's 30% plus or minus 5%. So great options for our patients, great debate, but we can do better. We can do better, and we're seeing that now. And I didn't think I'd ever say we could do better weekly taxanes. I hoped it. I hoped it. So RDXD, a lot of work done by the people on this stage. Katie Moore, one of them. 50% overall response rate. This is updated data. RENA-S, 55.6% overall response rate. Similar populations at 120 milligrams. We have LY, and so I'm not going to say the whole thing. Katie was doing it today. T-SAM or Torvu-SAM. So we added on the next slide. But okay, where we're seeing is 50% intend to treat. What are we seeing very consistently on Topo 1 payloads? 50% plus or minus 5% overall response rate. Very consistent. But we have a number of trials. Oh, forgot T-SAM. I apologize. Okay. So when we see this, when we look at this again at a 50% plus or minus 5%, 4 drugs, all Topo 1 payload with some different mechanism of actions. And to that point, payloads here are almost all Topo 1 payloads. Can we use a Topo 1 payload after a Topo 1 payload? We don't know that yet, right? Targets, folate receptor alpha, CDH6, NaPi2b, MUC1, B7H4, HER2. We're seeing different targets, very consistent. Again, higher numbers in the upper 4, smaller numbers that were presented as ESMO and IGCS. But the point here is we're developing this almost completely with Topo 1 payloads. That's going to be really difficult for us. While we transition, bring Ramez up and talk about some of the current trials, how are we going to do all this, guys? How are you going to look at this? Who wants to take this?
I'll start. We all have to work together because we can't do these at individual sites. These will affect eligibility for subsequent trials. So we're just going to need everyone's help to get these done. But I think these will be different. They'll be different. They have diversity of target. Even though they don't have payload diversity, they'll have different schedules, different toxicities. Biomarkers will or won't be important. And then, look at the success that we've had with MERV and TDXD, and to expand that. So this work has to get done. These are incredible preliminary results.
And I misspoke, Sophie M and
Yes.
TSAM, I apologize. So I was one slide ahead. So Brian, you raised your hand.
Yeah, until we know otherwise, for Topo 1 ADCs, it's one and done, right? It's cool. The first part of your talk was let's do 1, 2, and 3 in a different order. Here it's going to be which one can we give? So I think to Leslie's point, it's the intricacies of the responses and the side effect profiles at the second or third line of therapy, and then moving them forward. Which ones can we see in the platinum-sensitive setting? Which ones maybe in the first-line setting, if they're more active? In some ways, it's which is better. In some ways, it's a race. And that's the key. Again, we focus on this whole meeting. You got to enroll in clinical trials so we can get these answers. But
We're not doing cross-trial comparison. But when the patient's sitting in front of you, the biomarker will make a difference. The schedule will make the toxicity profile. We were talking earlier today. If you have a patient with a history of pneumonitis versus a history of somebody who's had trouble with mucositis, those things are going to make a difference to our earlier point. But my hope is that we have these available to us earlier lines of therapy, and we'll have those markers at the very beginning, and we'll be able to make educated guesses. So we'll have to cross-trial comparison, go from that to make a recommendation to the patient, and hopefully one day have trials which compare and look at the different biomarkers. Ramez, why don't you take us to talk about the amazing portfolio we have here?
Thank you, Dave. And continuing this important conversation and building. So we've discussed data that's emerging, looking at antibody-drug conjugates, as was already alluded to, many with Topo 1 payloads. But we're also seeing a natural evolution of drug development moving from later lines of therapy to earlier lines of therapy. This is data that's in the public domain. There is a lot of development happening in this space, so please have that contextually in your minds as we have a discussion like this. But we have frontline, newly diagnosed maintenance studies, HER2 targeting ADCs. We have several platinum-sensitive recurrent ovarian cancer clinical trials looking at both TROP2 and FR-alpha targeting ADCs. And then we have several platinum-resistant studies that Dave has already discussed and alluded to. So as a team, colleagues on stage, those of us sitting in the room together, how do you operationalize the conduct of these studies at your institutions? When you're getting outreach about clinical trials and activating studies, what are you doing rationally to make sense of what you're opening and how you're opening these trials? Anybody?
You guys heard me the other night. I want some other opinions.
Yeah.
Well, I agree with
ahead,
you,
Rob.
Dave. I think what you said the other night was spot on. I think it's portfolio management, and it's also your local resources. So we have to clear a bar that shows their scientific intent, scientific validation. So there's a strong signal that would hypothesis that can be supported by science. Then it needs to be whether or not where does it fit in our portfolio, and then what are the resources that we have available? Because there are a lot of trials that were actually fit nicely into the portfolio, but we have, don't have enough staff. So it's a combination of factors.
Okay, go ahead.
I think some of the challenges that I see that even though they're targeting a certain biomarker, most of these trials are not screening for a biomarker. So you can essentially enroll all comers right now. So sometimes it's a challenge. I mean, you tell us that I should be focusing on cadherin-6 when maybe it's not so important for RDXD at this point. So we don't really know that. So I think that question is still missing at this point of the biomarker. Does it really matter if you're going to enroll all comers at this point?
Got it. Go ahead. Bhavna and then Rob.
Yeah, and I think to that point, Dave outlined very nicely the other night, thinking about having a platinum-sensitive trial, one that's biomarker directed and one that's not, so you can make sure that all your patients have a trial opportunity.
Great. Can I ask, just for the sake of time, because there's a lot I think is important to cover here, some controversial, some not, but Brian, you said one and done. Do you feel like pragmatically in practice that's going to happen? Or do you feel like in clinical practice, as was already discussed when we were talking about a weekly taxane-based regimen, do you feel like when we get trial results and we have 2 or 3 ADCs, some biomarkers, some non, that we are going to sequence them and then figure out what happens with real world data. Go ahead, Rachel.
Yeah, I just wanted to say, we see in our patients treated with MIRV that folate receptor alpha expression goes down when they progress, right? So, maybe then you can just give them the same payload, but with a target that's still expressed on those cells. So I think there's still opportunity beyond the payload with having multiple different targets to be able to sequence these drugs.
I think to that point, and Dave, I'll come to you in a second. Katie, you have talked about this a lot, which is mechanisms of resistance. We don't really understand yet at all how these mechanisms of resistance evolve. Do you feel like we're going to be obligated to try to figure that out? I remember in training we talked about reversing platinum resistance forever and ever and ever, and whether that's truly something we've accomplished. Or are we just going to say, look, as was already alluded to, there's these multiple hypotheses we're going to use and just see how it plays out?
Yeah, I think it's probably going to be a mix of both, to be perfectly honest. The scientist in me really wants to figure out the mechanisms of resistance because it might inform the sequencing. I use the example a lot of mirvetuximab, and then maybe I have another folate. You showed 3 folate ADCs that have topoisomerase 1, and maybe they're going to be a little better in folate receptor alpha high. But do you really want to use them before MIRV? Maybe you want to use MIRV first, and then use that one, and PFS1 plus PFS2 is longer than the reverse. So I think about these things at that level. But I think the reality is, at least what we've learned from breast cancer, where they have done a lot of these studies, especially with HER2, the DAISY study, and TROP2. When they've done on-tumor biopsies and multiple biopsies of metastatic sites and patients that have progressed on these agents, the mechanisms of resistance are diverse in one patient across multiple sites. And it's humbling just looking at mechanisms of resistance for the TROP2 antigen expression, not even getting to efflux pumps and other things that are present at that time. So I used to say that we need to figure out mechanisms of resistance, blah, blah. And I do, like the scientist in me wants to know. The pragmaticist in me, I don't know if that's a word, realizes that it's probably far too complex to even say that, like, I'm going to do a biopsy of this one site and figure it out. We're not. So I think it's going to come down to clinical use of these medications and kind of empiric and pragmatic trials that tell us whether or not sequencing works. I actually I hope we're not one and done with Topo1 payloads. I do think if they move into frontline and we have them for a time-limited period and then someone progresses 3 or 4 years later, I might use one again and it may work again, like platinum sensitivity. But that's going to take us years to sort that out. And I don't think we're going to learn that unfortunately, from biopsies. I think we're going to learn it from patients being, graceful and participating in our trials.
Agree. Dave, go ahead. Final comment.
Well, I think, there's a lot of concern of allowing a Topo1 payload after Topo1 payload. Oh, if I have I hear this from the sponsors, well, what happens if we have a higher pneumonitis, hematologic toxicity? I mean, they're really active agents. And my patients want to have access to a Topo1 after Topo1. So cohorts which allow this to answer this question, obviously in a phase 1 or 1B type setting, is really needed. I wish we could do multiple biopsies to figure out, but you're right. It is multiple different mechanisms of resistance. But the pragmatic aspect is we need to answer that question. We need to have Topo1 after Topo1 payloads, cohorts, as we develop these agents.
Okay, Rob, and then we'll move on.
Just two quick comments. So one is that the technology for ADCs is obviously continuing to expand, and so all components of the ADC are under evaluation. And some of this issue about the biparatopic antibodies are there to help take care of the one issue of the biomarker expression, which could be overcome by using biparatopic or triparatopic antibodies. The other thing I want to highlight is that all of these trials that have ITT populations are going to be evaluated with respect to biomarker expression. And we are going to be doing all this internal evaluation and cross-trial comparison to see if there is a signal, even if it's not stratified and they get an ITT population, we're still going to make that decision on the basis of expression.
So that ties into the next question I have for you all, which is exactly that. We talk, we see comments, non-biomarker selected, biomarker selected. In this evolution, do you have a preference? I'm kind of hearing the undertones, but I want to hear it more granularly. Do you have a preference for a biomarker selected strategy in your practice with your patients? Or would you favor a drug that you're going to say, I can use in everybody?
Anything that works.
What is it?
Oh, yes and yes.
Yeah.
I just want options. Both.
I think definitely.
You want
But
What's
you're,
that?
You're faced with that.
You're
assuming-
faced with it.
I don't
You're
know
gonna
what's
do
going to
it.
happen with Merck.
Yeah.
But if that happens, you'll have, I got relacorilant, all comer, and then I have, B96,
PD-L1.
PD-L1, which
We
is about
don't know.
75% of the patients.
We don't know.
Be interesting. Maybe they'll both be all comer indications.
I don't know. Or for the ADCs, if there's, to Rob's point, there's an efficacy endpoint, it's successful, but the diving into the details about biomarkers, there's some that may be biomarker selected.
Rob is right, though.
Yeah.
They're all going to be heavily interrogated,
Correct.
over-interpreted.
Yes.
And
And what are we going to do?
Yeah.
Go ahead.
Well, I think the one thing with the biomarkers, there's a natural inclination to like that, right? You're practicing precision medicine, it's exciting and so forth, until the biomarker's negative. And you wish that you didn't have the filter there.
There you
so
go.
It all changes. So I think it's a
said.
challenge to say that it's always biomarker. To me, the biomarker almost has to ensure there's a significant bump in efficacy.
there you go.
If it's not, then I'd much rather have something that doesn't, that I can treat all my patients with.
That's a good summary.
Perfect. What are your concerns about the ADC development programs? I think everyone here universally has protocols open. You've used it in standard of care. You have clinical trials open. You're enrolling. We talk about duration of therapy. We talk about ADC. What are some emerging things, and what kind of tips and tricks might you offer, Bhavna?
I mean, the one thing that I would really like to see is that we increase the number of prior lines of therapy, because we're seeing efficacy even in more pretreated patients. So, this narrow 1 to 3, I think, is just not
This is P-Rock.
a great way to really limit enrollment. And, and I think the other area that I think is really important is that we be really thoughtful about the interval for maintenance therapy. I mean, ADCs are like chemo, and they have, effects on marrow and other side effects. So I think we have to be very thoughtful about, making sure that we don't continue treatment for long periods.
Got it.
I think one of the, you go ahead.
I was just going to point out what Bhavana said, that I think quality of life and durability is going to be really important. I mean, we see very high objective response rate, but we see that with the weekly paclitaxel and bevacizumab as well. So I think they're in the same range, but whether the response is going to be durable, are we going to be really pushing that progression-free survival and potentially overall survival also with the ADCs? I think that's still a question that we haven't answered yet.
Got it. Katie, go ahead, and then Dave.
Yeah, I think from a trial standpoint, things that things I worry about. Exactly that point, and like Mirasol, 50% of the patients came on with 3 lines. Not many had prior PARP. No one had prior immunotherapy. There was no prior ADCs. That's a very different population that's going to come on some of the studies that Dr. O'Malley presented over time. So you're going to see patients coming on now, maybe with immunotherapy. Maybe more patients, 30% maybe have, or 40% have had prior MIRV. MIRV has a risk of pneumonitis. IO has a risk of pneumonitis. They have cumulative hematologic toxicity. And now we're going to do a Topo1 ADC on top of that. We may start to see a side effect profile that we judge an agent by and say this is a toxic agent, when it's more based on the previous treatments that the patient received, because we have all these nice things now, rather than the agent alone. And we're going to be putting we're going to be making these value judgments of ADC versus ADC when the populations that were tested may be very different from one another moving forward. So I do wonder how we're going to sort that out when we have 5 topoisomerase I antibody-drug conjugates approved and they have different side effect profiles, like what's really the drug and what's the cumulative effect of what we've done to that patient. And then how do we account for how that patient does on that drug from a toxicity standpoint and a quality of life standpoint? And does that impact sequencing? And and these are all the things I think we're thinking about moving forward.
Dave, I'm gonna go to Brian because he's been waiting patiently for a while, and then I'm gonna come to you, but just quick comments.
Yeah, no, I was just going to say, what I'm most excited about ADCs is, in the later lines, does it work? But as we move earlier on, can it replace? I mean, the maintenance therapies are exciting, but can it replace a taxane in a second-line therapy? For two reasons. One, it could give us better efficacy there. But then two, it makes the patient more taxane-free if it means anything. So those studies are going to be real. All of them are exciting, but those in particular are interested in changing the care.
Chemo replacement strategies. Dave?
The effort that we make in finding and enrolling patients, we need to make as much effort in mitigation strategies and to improve quality of life and making sure we're looking at how to limit stomatitis. Our dosing schedule and treatment may be much different than it is in maintenance. So I think dose optimization has a big role here. We also need to look for unique ways to mitigate some of these symptoms. Maybe it's a longer delay when in maintenance, omitting doses, allowing for the body to recover, particularly if we're talking about, like in Gloriosa, Merv and Bev indefinitely. We need to look at those things to give the patients maximize quality of life, allow them to recover from the toxicities.
Great, thank you. So I transitioned the slide as we were discussing because we can't forget that there are also non-antibody drug conjugate-based systemic therapies in development in the platinum-resistant space. Again, this is not intended to be a comprehensive list, but representative of those drugs and programs that are further along in development potentially. You could see here some with additional lines of prior therapy, 4, 5, some with unlimited number of lines of prior therapy. We could see various mechanisms of actions, TP53 restoration, bispecifics, WEE1, CDK2, etc. What excites you guys the most?
All.
What excites you the most? All. Bhavna, is that it? All? That's what we're taking? All right, I'll ask.
I think it's a good answer because they're non-overlapping mechanisms, and there's some that have overlapping toxicity. And you've got some here that spare heme toxicity, give you breaks between. If you're talking about retreating with ADCs, you just said that intervening time interval where you're off that treatment for a while and you allow the body to recover. Like we just need to create like a more diverse group of options to be able to do that sequence.
Yeah, and I will echo also, you could see some of these are biomarker restricted studies. Some are, again, all-comer studies. So it ties into the conversation we had before about complementary protocols within your portfolio to allow you to capture all these patients, even in a non-ADC landscape.
Yeah, I don't want to repeat what Leslie said, that it's all and we're excited to have non-ADCs, but from our clinical trial perspective, one of these trials is important to have at your institution, not having a non-ADC trial to offer the patient after ADC.
Absolutely,
Yeah.
Agree. All right, the one other part of this conversation is the NCCN compendium updates. And this is something I feel like has been happening more and more frequently recently in terms of updates, references to various regimens. This is highlights, and I know it's hard to see because it's a very content-dense slide, but it just highlights some of the bolded items that are reflective of where things have changed. How often are you guys either having conversations with referring physicians, seeing in clinical practice, sometimes use of NCCN listed regimens that can sometimes preclude enrollment from trial?
Oh, yeah.
And
All
what does
the
that
time.
mean for us? Because we are seeing more and more regimens that are listed in NCCN based on phase 2 studies or earlier areas of development, and that can sometimes box out the opportunity for a patient to get treatment. How do we balance that? Because we also recognize that for some regions in which providers are practicing, this is the only way they're going to get access potentially via the payer to treat the patient. So where's the equipoise here? What do we do?
It's tough, right?
I'm not asking easy questions, guys.
No, it's a great question. I mean, I think we all work on this every day, and there's nothing more frustrating for us screening the patient themselves, where they're boxed out by, some ineffective therapy that was just something that someone picked off of a NCCN. I mean, there are pretty ineffective treatments on these lists. Mm-hmm. And I think that's really, frustrating. And I don't know what the answer is, except to just try to communicate, educate, get to know the people around you, get to know the referral base. I mean, most of the referring physicians are pretty excited about trials, especially in the GYN space, and do refer for studies. Some don't, some really want to keep those patients, but I guess you just kind of have to chip away at it every day.
Okay, Emmy, Dave, 27 seconds, then we got to move on.
Yeah, about the NCCN guidelines, I think initially when there were like very limited options, NCCN was maybe a bit more generous about allowing treatments on the guideline just to allow access. But I think as the treatment landscape will expand, I think it will be even more rigorous to control what goes on the compendium, because there will be a lot more choices that are going to be effective. Right. You don't seem to agree with that?
No, I hope so. I think we've added some stuff which is not as strong data. GOG partners, as we make this transition, we had about 40 to 50 of the same sites that got offered all the trials. Yeah. That is no longer the case. We have over 300 centers who are willing and asking to enroll on clinical trials and are engaged. So we've gone from just you have to get referred to one of these 40 to 50 centers to all of you having access to these trials. And so thinking about sequencing, offering them prospective data so we can answer these questions beyond a small phase 2 trial.
Agreed.
Thank you, everybody. It's my distinct pleasure to introduce Dr. Rachel Grisham. She's going to talk to us about data emerging in the low-grade serous ovarian cancer space, and then we'll follow with some additional discussion. Thank you.
Thank you, Ramez, and thank you for inviting me to talk about my favorite topic, because it has been a big, exciting year for women with low-grade serous ovarian cancer and the care teams that support them. So the NGOT OV60 GOG 3052 RAMP 201 study showed the durable activity of avutometinib and defactinib in women with recurrent low-grade serous ovarian cancer, particularly those with a KRAS mutation, where the response rate was 44%, with a median PFS of 22 months and a median duration of response of more than 31 months. And so these incredibly exciting results led to the accelerated approval of avutometinib and defactinib for women with recurrent KRAS mutant low-grade serous ovarian cancer just a few months ago, the first ever approved drug for women with low-grade serous ovarian cancer specifically. So this was a huge accomplishment for those women, but it's incredibly important to also note that this combination also showed activity in women who were KRAS wild type, which is about 2/3 of our patients with this disease, but to a lesser extent, with a median PFS of 12.8 months. Now, those results were not surprising because we know that KRAS mutation status is a prognostic marker for these patients, and that patients that are KRAS wild type have poorer prognosis and worse responses to both standard of care chemotherapy and targeted therapy. So importantly, we eagerly await the results of the GOG-led confirmatory phase 3 study, the RAMP 301 study, which is enrolling women with recurrent low-grade serous ovarian cancer with or without a KRAS mutation, and randomizing them to treatment with avutometinib and defactinib versus physician's choice of chemotherapy or endocrine therapy. But while we await those results, in the meantime, it's really important that we know the KRAS mutation status for all of our patients with low-grade serous ovarian cancer. And I just wanted to point out that I see increasingly at institutions that liquid biopsy circulating tumor DNA is being used for somatic tumor testing, but we know that that is not reliable in low-grade serous ovarian cancer. We looked at this in RAMP 201, and the concordance rate was 44% between identification of KRAS mutations in the tumor tissue itself versus in circulating tumor DNA. So you really need to be doing that testing on the tumor itself. But now that avutometinib and defactinib are commercially available, it's important that we know how to best mitigate and prevent toxicity from this regimen, because as we saw from RAMP 201, our patients on this treatment can expect to be on treatment not for months, but for years with this combination. So when I think about the main side effects of this combination, so avutometinib is an oral RAF/MEK clamp, defactinib is an oral FAK inhibitor. The main classes of side effects we can have include ocular toxicities, rash, LFT elevations and bilirubin elevation, and then elevated blood CPK. So just to quickly go through those, looking first at ocular toxicities, the great news is you don't need to take any prophylactic eye drops, you don't need any cooling devices, but you do have to see an eye care professional before starting treatment, 1 month later, and then every 3 months thereafter. And this is because avutometinib, much like single-agent MEK inhibitors, can cause fluid accumulation in the eye, which can lead to blurred vision. And in fact, this does happen in 40% of patients. And usually when it happens during the first week when they first start treatment. But luckily, it usually spontaneously resolves without any need for dose reduction or dose discontinuation. But it's so important patients know about that side effect that can happen. The rash we see is usually an acneiform rash on the face and upper chest area, particularly in sun-exposed areas. I have all my patients take a prophylactic antibiotic for at least their first 4 months on treatment. I use minocycline 100 milligrams BID. And I also tell my patients to avoid excess UV exposure. And if they develop a rash, we use a topical hydrocortisone cream. These drugs can cause LFT elevation, so those have to be monitored on treatment. But it's important to note that when patients have an isolated bilirubin elevation, that's usually from the defactinib, because it affects the enzyme that metabolizes and transports bilirubin. So usually holding defactinib alone will lead to a decrease in the bilirubin and then can be resumed at the same or lowered level. And then elevated CPK, this is a side effect of all MEK inhibitors, including avutometinib, and needs to be monitored while our patients are on treatment. Luckily, the CPK elevation is usually asymptomatic, but in rare cases can lead to rhabdomyolysis, and so we have to monitor for this and make sure our patients are staying well hydrated and avoiding any incredibly excessive new exercise regimens when they're on treatment, but they can still maintain their normal activity. So we now have the lucky problem of having multiple available targeted therapies for our patients with recurrent low-grade serous ovarian cancer. So trametinib and binimetinib, both single-agent MEK inhibitors that were evaluated in phase 3 studies, and then more recently, cobimetinib was evaluated in the Bouquet study. So when I think about what regimen to offer my patients, I look at the schedule, the tolerability, what their prior lines of therapy have been, it's always so important, and then of course, what is available. So looking first at schedule, so trametinib and binimetinib are definitely going to win this one. Trametinib is given once a day, every day. Binimetinib is given twice a day, every day. Cobimetinib, a little bit more complicated, 3 weeks on, 1 week off. Avutometinib and defactinib, much more complicated. So avutometinib is given by mouth twice a week, 3 weeks on, 1 week off. And defactinib is given by mouth twice a day, 3 weeks on, 1 week off. So that is a complicated schedule. It's important that our patients have tools to help them with compliance, whether that be a pill diary or an app on their phone or a refrigerated pill box or a combination of all three. But I do think that this schedule is what helps so much with the tolerability of this regimen. So as Dave was just saying, it's so important that we think about new and novel dosing schedules to make these regimens more tolerable for our patients. And I think avutometinib and defactinib has that. Because by having this intermittent dosing and this recovery week each cycle, I believe we see less cumulative toxicity. And when we look across the studies, we see that in the studies of trametinib and binimetinib, about a third of patients discontinued treatment due to toxicity. While in the RAMP 201 study, only 10% of patients discontinued treatment due to toxicity, despite being on treatment for years. And then when we look at prior lines of therapy, trametinib, binimetinib, and cobimetinib are all single-agent MEK inhibitors. So the studies, of course, did not allow patients to have received a prior MEK inhibitor before going on study. But avutometinib and defactinib actually have been shown to be active in patients who have received a prior MEK inhibitor. So I think it's really important to note that a quarter of the patients on the RAMP 201 study had already received a MEK inhibitor before going on treatment. And amongst those patients with a KRAS mutation, the response rate was still 33% in those who had received a prior MEK inhibitor. So I think that's important to take into account when we look at prior therapies. And then, of course, availability. Avutometinib and defactinib is currently the only FDA-approved treatment specifically for low-grade serous ovarian cancer. But trametinib is NCCN 2A listed, binimetinib is 2B listed, and cobimetinib FDA approved for other indications, but not currently approved or compendium listed for low-grade serous ovarian cancer. And so then moving away from MEK inhibitors, I just wanted to highlight the huge achievement of Dr. Slomovitz and colleagues in publishing GOG 3026 last month. Such an important study that looked at the activity of the CDK4/6 inhibitor ribociclib in combination with letrozole for women with recurrent low-grade serous ovarian cancer. And so that study showed an impressive response rate of 30.6% with a median PFS of 14.5 months. And so I hope this becomes an available therapy for us very soon for our women with recurrent low-grade serous ovarian cancer. And then in my last 10 seconds, I just wanted to really quickly say, we're talking so much about ADCs here, and it's been such an important progress for our patients to have the development of multiple different ADCs. But many of these targets that are highly expressed in high-grade serous ovarian cancer, like folate receptor alpha, B7H4, and others as well, are also highly expressed in low-grade serous ovarian cancer. So it's really important that we keep low-grade serous ovarian cancer in mind when developing these clinical trials. Because while it's a huge achievement to now have one drug FDA approved for low-grade serous ovarian cancer, in the future it would be great if we could have multiple. Thank you.
Rachel, that was great. I want to thank you for what a great talk that was, and what a stroke of luck and genius that we were able to match you to your favorite subject. So thank you. All right, so I'd now like to introduce part 2, the Evolving Endometrial Cancer Treatment Landscape Approvals, Evidence and Impact. Dr. Katie Moore and Dr. Slomovitz will lead this section. Dr. Moore, I think you're up first.
Okay. Ready? Okay. All right, well, good evening, everyone. I'm very pleased to lead off this section on endometrial cancer with Dr. Slomovitz. And when we were thinking about, the highlight reel and what we're going to highlight, one of the things I think that's emerging is there's new agents, but with that comes new understanding of the biomarkers and some confusion, actually, around the biomarkers, especially in endometrial cancer. And so we thought it would be fun to start developing maybe a deck around what's evolving and what we're learning and what we still need to understand in the biomarker place in endometrial cancer. So I'm going to attempt to do that. And so when we think about the evolution of endometrial cancer, really since the phenomenal presentation of Ruby and NRG-GY018 that ushered in the absolute necessity for mismatch repair testing, that goes without saying, this has become kind of a no-brainer. We all get this, right? That we have to know mismatch repair status, because if we find a deficient mismatch repair tumor, whatever immune checkpoint inhibitor you use, and we can argue PD-1 or PD-L1, but they're pretty darn consistent in that they work really, really well. And I think we'll see over time whether or not we have cures in populations of patients who really had a 20 to 30% chance of 3-year survival during my lifetime. So this is sort of one of the miracles of kind of the age. But just like BRCA and PARP, we leave people behind. And so while this is transformative, about 30% in every one of these studies of DMMR tumors recur during the first, not even the first 2 years, first 12 months. And why is that? Can we identify this population with biomarkers and intervene and try to reverse this and rescue this? This is sort of the study. And so there have been some exploratory analyses that have tried to look at this. And if you'd asked me when this came out, I'd been like, oh, it's certainly methylation. And Lynch versus methylation, that's certainly what it is. And it is not. And so that's been looked at in NRG-GY018 and Ruby. Both, I'm showing you just 2 of the survival curves. Both of these curves are showing patients, all of whom received the immune checkpoint inhibitor, and then looking at methylated versus non-methylated, and there's no statistical difference. And so exploratory analyses, but doesn't seem to even be a signal there. So that was a little bit disappointing. What about PD-L1 status, specifically in DMMR? We just saw this. So this is a new paper, for those of you that haven't seen it, in Nature Medicine by Dr. Eskander, where they looked at a number of the biomarkers, including PD-L1. And here, there again does not seem to be any correlation between PD-L1 levels by CPS score here and efficacy in a CPS greater than 1 or less than 1. And so this doesn't seem to be something we're going to use. What did we learn, or what did we I guess what did we learn? What was suggested at ESMO this year? So there's an interesting exploratory subset analysis of the ATTEND study, and that's what I'm showing you. I'm going to show you a couple slides on this. On the left, where they looked at patients, this was the atezolizumab study, where they looked at patients that were DMMR, thus far that's what they presented, and they identified CT and NB1, or beta-catenin, and our APC mutations as potentially negatively prognostic. And these were found in about 20% of deficient mismatch repair tumors, and the hazard ratio for PFS amongst this group of patients, DMMR, who received atezolizumab when they had a beta-catenin mutation versus not, was 1.91, so a 90% worse PFS if you had a beta-catenin mutation. Exploratory analysis needs to be confirmed, but this isn't new-ish. Remember PORTEC, and this is a little bit old, some of you are not this old, but in 2016 we saw the PORTEC combined analysis where we started to get what led to PORTEC 4A, which we're going to talk about in a moment. What were the molecular biomarkers in early stage endometrial cancer that identified tumors that were in trouble? And what they came up with here was beta-catenin, and these were not DMMR, beta-catenin and L1CAM. And that kind of fed into PORTEC 4A. So we've heard the beta-catenin story for a decade. Here we're seeing it again in DMMR. Is this something we need to be testing for and thinking about? Also from ATTEND, a separate analysis, they looked at aneuploidy. And I bet you're not surprised to know that tumors with high aneuploidy do worse than tumors that don't have high aneuploidy. But we've never really looked at this, and this is pretty striking. Again, it's about 10% of DMMR tumors have high aneuploidy and had a substantially worse prognosis, and even when given atezolizumab, it didn't correct for the fact that they were high aneuploid. What we don't know is, does beta-catenin and aneuploidy overlap? Is this the same population? Is this different populations? We don't know this yet, but this is hypothesis generating for moving us forward and thinking about whether or not these are populations we can identify, and if we can, what can we do about it other than just knowing that the patient's going to do a little bit worse or substantially worse? How about DMMR or PMMR? There's a modest benefit in progression-free survival, not really a benefit in overall survival, but some patients seem to do really well. Can we tell who benefits here? And this is another place where we're really trying to figure out, should I use this or maybe I should move to something else? And so this is an analysis that Shannon Weston presented last year at ESMO from DuoE, where they looked at tumor mutation burden high and also microsatellite instability. These largely overlap with DMMR, and so the data is very consistent. But 13% of the DMMR tumors were actually tumor mutation burden low, and 10% of the DMMR tumors were not microsatellite high. And these are maybe the same populations, but again, maybe a little bit different. The numbers are too small for us to run PFS curves, but you could probably postulate that these tumors don't do as well when you give them an immune checkpoint inhibitor as others might who are tumor mutation burden high. And so gathering some cumulative data here may help us to identify these patients and do a different therapy or in addition to an immune checkpoint inhibitor if we confirm that this is a patient population that does worse. That had little arrows there. Next is the molecular subtype. There was a hypothesis from the RUBY study that in the PMMR population that those patients with TP53 mutations did very, very well with immune checkpoint inhibitors. And we all were like kind of, whoo, well, that's surprising. And then TP53 became sort of the hot biomarker. We looked at it in DuoE, and these are all post hoc exploratory analyses, and the hazard ratio in DuoE was 0.8. So it did not hold, although how TP53 was assessed was different in both studies, and that really goes to the consistency of how you're measuring the biomarker being also as important as the biomarker itself. So this is not a confirmed biomarker, predictive biomarker of response yet. It may never be for benefit of immune checkpoint inhibitors. So this is just a little chart, and I think you're going to get these slides. I'm going to probably keep adding to this as more data comes out. As we're making decks. But we're thinking about DMMR. DMMR is the biomarker right now. If you have a DMMR, like you don't overthink it using an immune checkpoint inhibitor of your choice. Methylation, PD-L1, homologous recombination repair genes. None of that really has given us a big hint of who these patients are, whose tumors are at highest risk for recurrence. But aneuploidy and beta-catenin are of high interest. And then PMMR, just as I went through, there's a lot of contenders here, TP53 amongst them, but still a lot of work to do to try and identify those patients who really, really benefit, and maybe those for whom there's enough clinical equipoise to move to other things. And so with all these biomarkers just swirling around, are we ready to start using molecular profile plus minus additional biomarkers to individualize therapy? Well, we already are, kind of. If you think about B21, which was a negative trial because of how it was designed statistically, 1,000 patients with kind of receiving adjuvant chemotherapy with or without pembrolizumab, negative study, but in the post hoc exploratory analysis in the DMMR group, which I'm showing you on the left, the hazard ratio was 0.31. And this may lead to a regulatory decision, at least outside the US, if not inside the US, that remains to be seen. But a lot of people have picked this up, and we can maybe discuss whether or not that's the right thing to do. We just also had the publication of PORTEC 4A, and I'm showing you here on the, like right in the middle, you can see how PORTEC was set up. So these are clinical stage 1, and they had molecular profiling, and if they're POLE, they were called favorable. If they were mismatch repair deficient and beta-catenin, and mismatch repair deficient, not mismatch repair deficient, sorry. If they're proficient and beta-catenin wild type, they were favorable. If they were proficient and beta-catenin mutated, they were intermediate. If they were deficient mismatch repair, they were intermediate. And then if they were L1 CAM or TP53, they were unfavorable. And then they individualized the adjuvant therapy to observation, vaginal cuff brachy, or external beam radiation, or in the control arm, everyone got vaginal cuff brachytherapy. And so what did they find? Well, what they found is that this is a non-inferiority study, and so the conclusion of the study is that using molecularly gated radiation was non-inferior to just everyone getting vaginal cuff brachytherapy, and that you could spare those in the favorable group any kind of radiation, which is a nice thing to say, and we can talk about that. But in the intermediate profile group, which is where your DMMR patients are, this is still called non-inferior. And so maybe it's true, but is it really relevant to how we're thinking about it? So if you think about local regional recurrences in this intermediate profile group, that they're mostly DMMR, it was 13% with vaginal cuff brachy. And remember that these were clinically staged, only 25% had lymph node dissection. So compare that to B21. This is apples and oranges, just hypothesis, and we can talk about it. So this is DMMR for B21, 75% stage 3. So my point here being that probably some of those clinical stage 1s were actually node positive, so they're stage 3, and they only had one local regional recurrence when they used pembrolizumab maintenance. And so is this even a relevant study given this analysis, apples and oranges, but something I wanted to bring up, for the group? I think moving forward, we're going to be integrating ctDNA, and this is a study called Signal EMC. We're already trying to stratify, we talked about this in ovarian cancer today, ctDNA negative and positive, and to triage adjuvant therapy based on MRD. So this is a very exciting clinical trial. And then of course we all know the Rainbow study, which is kind of taking a different approach than PORTEC 1. There's no beta-catenin here, there's no L1 CAM, it's all based on molecular profiling and really integrating radiation plus a therapeutic. So I think we're going to have a lot of conflicting data here with the biomarkers and their predictive capability and what we should be selecting for patients, especially with early stage cancers, much less late stage cancers. So I think it's going to get a little more confusing before it gets clear, but I think there'll be some things for us to discuss with the group. And with that, I will stop. Thanks.
Let's keep it rolling, Brian. While you're coming up, though, I want to ask a few questions. So this is a new discovery for me personally, that beta-catenin mutations are a bad thing, and that requires there are mutations in that exon 3. Thank you, Katie. It was excellent. But I generally don't do NGS in a high intermediate risk patient. If you can identify the molecularly low risk, you can avoid brachytherapy, which Portex says everybody needs if they're high intermediate risk, in more than half the patients. So there's real value. It pays for the NGS because you're avoiding brachytherapy.
More than pays for it.
More than pays for it. And if they're really high risk, then you give them external beam. So it's a dose de-escalation and dose escalation. The question is, and we can ask Leslie and Ramez, do you guys do currently NGS, and are you going to start in these patients that have uterine confined cancer, the high intermediate risk?
I mean, it's a really good question. I mean, this advocates for that, right? And I wonder, are there markers that we're not even aware of yet? Is our current, the TCGA classification changed the world, but is it the end-all be-all? Is that the end state of our biomarker development? I don't know. I think that in my mind, we need to pick out the patients who are going to fail radiation. I mean, here in Portec 4A, they're giving the unfavorable P53 mutated patients radiation and no chemotherapy. Like, in my mind, those patients are probably better served by more systemic treatment, but we haven't proved that yet. I think many of us believe that and haven't proven that yet. So I don't know if that exactly answers your question, because for me, I still have
really.
other questions before I get to that question, right? Yeah. I'm still stuck on my old questions.
I think if we have in-house NGS, it's a little easier sending it to a lab. Go ahead, Bhavna.
Yeah, no, I would advocate for testing in early stage endometrial cancer,
Right.
especially with this data. And I would also like to add that, in other diseases like colon and bladder, ctDNA was a more powerful, tool than any other biomarker in terms of determining adjuvant therapy. So I think, this signal EMC1 is going to be really important as we decide what we need to do.
Go ahead, Ramez. And also this L1 cam, because I didn't know. We had tumor board every Tuesday. I asked my pathologist, and she says, what? So we're going to have to look into that. So you go, and then Rob goes, and then we'll turn over to Brian.
I agree completely about the ctDNA tying into the trial that was presented. Yeah. But also, we have NRG GY020, which was a high intermediate risk DMMR Pembro.
Right.
Vaginal cuff breaking.
Right.
Who knows what that's going to show? And that's going to evolve the therapeutic landscape for the DMMR totally if it shows a clinical benefit and outcome, and the other biomarkers are going to be in the DMMR will disappear because that's what's going to drive your...
Exactly. And right now we're saying, do they need Pembro? But really, should we be asking, do they need chemo?
Dr.
Can
Backus,
they just get Pembro?
Dr. Backus, I see you in the back of the room. Are you ready to give us the results of GY020?
Thank you.
Yeah.
Okay, we're waiting.
So, the thing that's interesting about Portec 4A is the decision about what to do was already made ahead of time, right? So they've already allocated treatment based on what the impression was that they needed to treat. Yes, with no treatment for one arm, pelvic radiation and
Vaginal cuff.
And vaginal cuff. So they've made that already. Now they go back and try to prove that that was the case. But in the clinic, we look at so many other factors. The grade, these are high intermediate risk, but in the high intermediate risk, there are several subgroups within that have differential progression risks. And we make those decisions at that level. So just using this on the Portec 4A discriminators, to me, is not sensitive enough.
But it was a pretty homogeneous group of patients based on histopathological.
They're high intermediate risk, but there are multiple factors. Like, did you see what the LVSI?
Not surgically.
They don't do lymph nodes. Nobody does lymph nodes but you
there's
guys.
no lymph nodes. I mean, so I'm saying,
Katie had a
it's,
comment.
I just want to, so I agree with that. I agree with what you're saying. I wanted to be just careful because I don't think, outside of Rainbow, where we are doing some molecular profiling, if you have that open, please do. I don't really think, to answer your question, Brett, I don't think we should be doing NGS on early stage patients based on Portec 4A. That would be my take home. The beta-catenin, and I think what you were trying to say is, if they have beta-catenin, they weren't randomized to two different arms to see if the beta-catenin is predictive of that response.
Exactly.
The beta-catenin all got vaginal cuff brachy, and this is how they did. And so all we can say right now is that it's a good potential stratification factor, but it's not one that's predictive of some sort of therapy based on this study.
That's right.
Same with L1 CAM. L1 CAM, I don't know if that's how you say it. There are 44 patients with L1 CAM. Recurrence risk was 20%. And these are clinical stage 1 patients. So you would say, well, that's pretty high. I want to treat them. But of those 9 patients that recurred, 6 of them were TP53 mutated as well. And then 2 of them were no specific mutation profile, but ER negative. And we know that group is an incredibly high risk group. And so they had, to your point, other findings. So I would not want this group to walk out of here thinking they should start screening for these and acting on them. At this point, I think that would be not the right, personally not the right take home.
And I didn't ask the question if we should use it. I just want to know if we should test our tumors.
I hear you.
But keep going. Let's go, Brian.
Hang on one second. Katie, just one quick question. How are you using the aneuploidy data in your DMMR subgroup?
Well, I'm not using, I mean, I don't even know how you test for aneuploidy. I mean, it's whole exome sequencing.
That's
not
easy to get.
something, that's not easy to get.
but that's
And it's 9% of DMMR. I hope that Rama's tests for it in 018, and I hope Shannon and I test for it in DUO-E so we can see if it's a consistent finding. And then I think we need to look at it prospectively. But then the question, Tom, is, okay, if I find it, what do I do about it? Like in a patient, I'm like, well, you're DMMR, but you have aneuploidy. Meh. I'm still just going to give you pembrolizumab. And it's not going to work.
Or just start with
So, what do I do about it? I think is the challenge
Yeah, so
moving forward.
Thanks. Brian, take us away.
Yeah, thanks. That was great talking. Thanks for allowing me to be here and to give this talk. It's something that obviously we're all very, very passionate about. So we talked about the ADCs in ovarian cancer. That's the direction similar to what we're doing in endometrial cancer. A lot of things going on. As far as testing up front, and we'll get into this in the ADC talk, I like knowing as much as I can about the patients, of their tumors earlier on. I know, Bob, you're doing universal testing on all of your endometrial cancer patients, right? For the most part, molecular testing. Yeah. That information is valuable, especially I'll talk about with ADCs as we're going through. Here's some of the key data, but we're going to be moving them to earlier and earlier lines of therapy so that if they have a certain overexpression or mutation, it'll be nice to know. Here's some of the key data on ADCs. This is a laundry list. It's not complete. There's others that are also out there. You can see the data on the sacituzumab govitecan, the TDXD, Rina-S, really exciting data. They presented 50% response rates at the last series of meetings. SAC-TMT, the Puxisam, Stephanie Gaillard presented some nice earlier data on the B7H4 topo-1 isomerase inhibitors. RDXD as well, and there's not only one HER2 ADC, but there's others that are out there that are very, very active. And again, you'll have these slides. The purpose here isn't to have you memorize this. So where are we incorporating it? Just sort of like we did with IO therapy, just like we did in a lot of other diseases, let's go second line and see where we can go from there. This is sort of like the standard design of what we're doing in our second line trials. Okay, it's second line trials, novel ADC versus physician choice chemotherapy. We borrowed from what we did in 775. The control arm is weekly paclitaxel, adriamycin. Whenever I give this talk, I remind people adriamycin is active in endometrial cancer. Liposomal doxorubicin is not. That's the control arm. And the key here is to just, second line endometrial cancer, we're treating to help prevent disease from coming back. It's palliative. It's not curative. So here's our current portfolio so far, okay? And the list is going on and on and on. Congratulations again to Bhavna and to Ramez completing the sacituzumab govitecan trial, the SAC-TMT trial. Florbacus now recently opened up the BNT, 323, with the HER2 ADC. We have an FDA approval. Right, we want to go on trial, but we also have an FDA approval with TDXD 3+, NCCN 2+, 3+. Puxisam, again, this is being led by Stephanie Gaillard with their B7H4. We have the other, these names are sometimes very difficult. Mosertag Rezatican is a new asset that we're looking at, as long as the Rina-S, and there's more and more and more coming. Again, the key to these, and I'm looking forward to our discussion, is to figure out when, what line of therapy, and which one to use, biomarker directed or not. Well, if we're evaluating it carefully in the second line, let's see what we're doing also in the first line. Two types of trials in the first line. Okay, there's the maintenance trials that you could see on the left. They're pretty much giving the standard of care, the chemotherapy and the immune checkpoint inhibitor, then randomized to the standard of care, immune checkpoint inhibitor, versus novel ADC with immune checkpoint inhibitor. That's on the left. On the right, it's sort of, and this was what I was alluding to earlier, not a maintenance approach after traditional approach, but it's replacing the current therapy, which is a design on the right. This is from GOG 3098. This is the Destiny-01 trial. Standard of care is Arm C. Arm B is the novel ADC, replacing the chemotherapy. ADCs are chemo, but replacing the carboplatin and paclitaxel with the immune checkpoint inhibitor. And in the Arm A was novel, looking at a bispecific, an anti-PD-L1 TIGIT bispecific with the novel ADC. The study on the left, the current portfolio, GOG 3109, looking at SAC-TMT. In the maintenance setting on the right, I alluded to the trastuzumab deruxtecan. Two more trials, and there's more and more coming. Even in the adjuvant setting. Okay, now so we talked about what we're doing second line, first line. In the adjuvant, in the HER2 positive patients, okay, this is a study looking at TDXD versus carboplatin paclitaxel. The control arm was carboplatin paclitaxel because B21 was negative. So we didn't need to add pembro in that group. Again, looking in the adjuvant setting, if we see a difference here, adding in an ADC, and I got beaten up a little bit when I said one and done, but that's okay. But if it is one and done, we're using it up in the adjuvant setting. What are we going to use later on? And a key point that was brought up: how long do we treat them with the ADC with no measurable disease? Here it's going to be 12 months. How did we get that? We got it. We borrowed some data from some ideas from breast cancer, but it's up and running. We're excited to see how this goes. That's the ADC world. Let's go to what else is there besides ADCs? Now this study, this is GOG 86P, really a novel 3-arm randomized phase 2 trial. And what sort of matured from this over the years is when they looked at the patients who were treated with carboplatin paclitaxel bevacizumab versus, it wasn't a comparator study, but looking at it versus the other arms that were done at the same time, the patients with P53 mutations, okay, had a better response, or appeared to be a better response when treated with bevacizumab than if not. Leading us to this current trial, and this is a trial that's led by Amanda Nichols-Fader and her team, just opened up very, very recently, GY035. 3-arm trial. It's pretty nice because there's no ADC here, even though we love ADCs. 3-arm trial, carboplatin paclitaxel pembrolizumab. Okay, this is the 868 GY018 backbone versus the 86P regimen, carboplatin paclitaxel bev, and then another of the experimental arms, carboplatin, paclitaxel, pembrolizumab, and bevacizumab, followed by pembro and bev maintenance. Okay, so we talk about PMMR, IO, yes, as a treatment option. There may still be other treatment options besides IO in the treatment of PMMR patients, and we're learning that. What about, and we sort of started this conversation, and I'm really excited to talk about this a little bit more. This is looking at the NSMP tumors. Okay, so we've divided into 4 molecular subclassifications, but is that enough? When we look at the NSMP tumors and look at them by estrogen receptor positivity, or if it's negative, clearly there's a different outcome here. You can see on the top the differences whether it's ER positive or ER negative with an NSMPs, and on the bottom you can see the differences by high grade, low grade, ER positive, ER negative. So is this something that we're going to treat differently? Are we going to push in some of the hormonal-based therapies now that maybe this is the group that will respond better to them, or avoid the hormonal-based therapies? Leading into this, what about the biomarker-based therapies? So another option for our patients that we often forget about. This cartoon represents some of the combining endocrine therapies with biomarker-directed therapies, not necessarily to work in parallel, but we know that some of these biomarker-based therapies to help overcome some hormonal resistance. Up on the left, PI3K inhibitor, alpelisib. This is a study that we're doing with Stephanie Gayard, GOG 3069, looking at that in endometrioid tumors with PIK3CA mutations, is there better effectiveness here? The CDK4/6s, we know that from the Paleo study. There's activity there. mTOR, we were fortunate enough through the GOG 3007 to do everolimus and letrozole. So really some exciting ways that we need to look at or relook at better treatment for the management of these patients. Here's really exciting data. This is ACR 368201. It's a CHEK1/2 inhibitor that's given to patients previously treated. Now, it's either a biomarker positive group that got the drug alone, or a biomarker we call negative group that got treated with a drug and what we call ultra low dose gemcitabine. This was recently reported out. 52% of patients with uterine serous carcinoma, pre-treated, giving this asset responded to therapy. 52% response rate in uterine serous cancers that were pre-treated. Really remarkable. This leads to a current trial, a new arm of this trial that we're doing on the right, where I'm excited about this arm. It's a phase 2 study, GOG 3082. Biomarker unselected. So we're not worrying about the pre-treatment biopsy. 2 or less lines of previous therapy, treating them with the CHEK1/2 inhibitor with ultra low dose gemcitabine, something that we're excited about moving forward. Biomarker-based therapies under development. I've mentioned this, abemaciclib. I mentioned the second one, alpelisib and fulvestrant. GOG 3039, led by Marilyn Wong. Abemaciclib, CDK4/6, letrozole. Look forward to an oral presentation at the SGO meeting coming up in the spring. GOG 3113, sapanisertib and cerebelisib, also known as a PIKTOR, with Taxol as an option for some of our patients. The NAB, sirolimus, and letrozole, really some exciting data presented at the IGCS by Lauren Dockery of another non-chemo, non-ADC hormonal-based option for our patients. And there's a new a class of drugs, what we call CYP11A1 inhibitors that we're looking at in a pan-tumor. A lot of exciting things going on. I look forward to our discussion.
Well, Dr. Moore and Slomowitz, thank you. Those were great, outstanding, really, presentations. And I think you really put a lot into perspective in a very short period of time. That's a big challenge, so thank you for doing that. We have a few minutes to open it up for comments from the panel as well as questions from the audience. So once again, there's a microphone in the middle of the room. Feel free to just go up there. And first brave soul, what do they win, Jenna?
Yeah, no, if there's no questions, I'm going to ask the panel some questions.
Okay.
So, and Bob, not to pick on you, but it's great you're doing all the biomarker testing on all of your patients. Are you going to treat a low-grade ER-negative tumor? Do you consider them differently, ER-negative, ER-positive? And that, forget about doing testing or not, we all have that status. Grade 2 ER-negative tumor, are you going to think about them differently than an ER-positive tumor?
What is ER-negative?
Stage-based.
Oh, that we're going to go there? We have 10 minutes,
Can you
not 10
define
hours.
ER-negative for us?
10% threshold.
10% threshold.
Okay.
And I'm going to, after Bob, you're in the second answer on that.
Yeah.
Yeah, for a low grade, I'm not going to, change my treatment, but I think in the high grades, especially with POLE, we have started to de-escalate those patients.
Interesting. Yeah, no, POLE, we haven't talked about that a lot, but the whole de-escalation, and we'll see from the Rainbow study, if it's
true.
True, then we could actually de-escalate the patients. Dave, I said you'll get the next comment, but adding to that, an ER-positive patient that recurs. We just talked about some of the biomarker hormonal-driven therapies. How do you choose between a CDK4/6 hormonal therapy versus a ADC trial?
Well, I think the availability, obviously, and I think if you have an asymptomatic or isolated patients, we see these patients isolated recurrences to the lungs, they're resected, they have no evidence of disease. So in that patient is not eligible for clinical trial because they don't have any measurable disease, then I have a conversation with them. But I think we have a trial which is, again, very high blockade of the steroid synthesis pathway, seeing if that makes an impact on these patients who, especially if they're estrogen positive. Now, if we also look, and again, if they're not eligible for clinical trial, have a conversation with them with regards to, using hormonal therapy. And I think that, to me, makes the most sense in an asymptomatic patient who is PMMR.
Great. Leslie.
Thank you. So, that data is provocative. And I think we all have experienced that our ER-positive patients do live longer. I mean, I know I've noticed that in my practice. but I hadn't like really intentionally used that information to inform what I do necessarily. But now that we have all these options coming down the pike, like that patient, even that higher risk patient that's ER positive, is going to have more, going to live longer, have more options, be exposed to more therapies. And the fact that we are developing, and thank you for your work, these hormonal-based options, CDK4/6, like these, again, bone marrow sparing options or different toxicity profiles, and you can stagger those treatments and keep them on different types of therapies.
Rob, and then I'm going to have a question for Ramez and for Katie. But Rob?
You have a question?
You go first, and then I have some more questions. I'm having fun.
All right, so just provocative, and I'd be curious to get anybody from the audience that wants to answer this question.
Okay.
So we obviously in the ER positive cases have a lot of interest in using endocrine therapy. And we know that we have combination strategies like CDK4/6 combinations that are useful in cases of endocrine resistance. Is anybody testing for ESR1 for these patients? Why not?
We should be.
We should be.
You should be
We
all the
are,
time.
and
Yeah, I'm not.
Yeah.
Not consistent.
We are or we're not?
Well,
Okay.
the med-oncs, I share a lot of patients with medical oncologists. And,
So-
and they're breast cancer doctors.
Yeah.
And so, right?
Yeah.
Does anybody out there do ESR testing?
Part of your NGS sample.
Just for for NGS.
It's on your, you'll get it.
You'll get a report back,
Yeah.
So do you use that before you start endocrine therapy?
Angus, can you go to Mike so we can hear you?
No.
Microphone, yeah.
So I guess just do a poll of the audience. How many of you get NGS testing for your patients with advanced or recurrent disease?
Exactly.
Yeah, I mean, so it's most. So it's going to come on that test. It's actually fairly rare for people to have an ESR alteration, but if they do, it may impact how you treat them.
Okay. And then so my next question is there an opportunity for us to study purely endocrine-based therapies as a frontline strategy?
Great question. This is something, I mean, it's a loaded question because it's something we've been talking about for a long, long time.
Yeah. Thoughts?
Well, this is, I am passionate about, you've heard this. The problem is, do you have to design a non-inferiority trial to de-escalate and give someone a hormonal strategy instead of cytotoxic chemo? Because if you look at the historical data, it's going to be very hard to exceed based on PFS endpoints. Do I think it's the right thing to do? Yes, because then you can give someone a hormonal therapy and spare them all of the adverse events that come with cytotoxic chemo.
Yeah.
But we have to have the appetite and the desire to do that.
Yeah.
So, and so in that design, how much, so it gets back to Katie's review of PORTEC 4A, the way we design non-inferiority trials is to come up with a threshold that we're unwilling to go below in terms of inefficacy. In PORTEC 4A, they had 7% difference was what they're willing to accept. What would you accept in a frontline study like that?
So, I'll tell you a super interesting thing I learned from a brilliant GU medical oncologist, Raina McKay, who I work with. They actually in prostate did this. And you know what they did? They gathered a room of patients. And they told them, what are you willing to accept as a risk? And then they built that data into the design of the study, and it was approved to move forward. And they accepted, I think it was like up to a 12%, I think it was, or something. It was a broad
difference.
Yes, and so I would love to get similar data in an endometrial cancer population. Let the patients tell us, what are you willing to accept to abandon cytotoxic chemotherapy? And what if they say 10, 15%?
Well,
There's
we
a
have
project for
to.
somebody.
There's
a project.
Avoiding it forever, right? Are you looking at a population where it's probably inevitable that they're going to need subsequent therapy?
So I'm gonna take the mic back for a second. Ramez, you worked your tail off GY018868 to make pembrolizumab the standard of care for all patients. What do you think about these studies now that are taking IO out of the first-line therapy? Is yours the standard or a standard? What are your thoughts about that?
So two parts to this. You have to look at the patient population that was enrolled on the trial because the eligibility is not completely overlapping in some of the studies. I think you guys have heard me say it. Checkpoint of your choice. But when you look at the data and you look at the survival, and by the way, the survival outcomes for these studies are continuing to mature, even in the PMMR population.
Okay.
If you have a therapeutic intervention that improves outcome, why would I withhold my most effective therapy? I wouldn't want that withheld from me. I'd want the most effective treatment strategy.
So is it wrong that we have some arms of the ongoing new studies that don't have IO?
I didn't design those trials. I'm here to,
So is he dropping back 10 and punting, or is he answering the question? I'm not sure. But, Katie,
I'll answer like Rob did. I'll ask you a question.
I'm here interested if you have any comments on that. But also, Katie, you and Shannon did a great job with DOE. One of the words we haven't mentioned tonight in the endometrial session is PARP inhibitors.
Yeah.
What are your thoughts on that? Are we still there? We're not there yet. We don't know. Where are we going with PARPs in endometrial?
So in the U.S., the survival cut point for DOE is coming, and I think that will be really the decision point for whether or not we really think there's a role for PARP inhibitor in a PMMR population. It is a positive study. We can all kind of argue about the statistics in the control arm. It is a little bit hard, I would just say a lot hard to interpret. And if you had Shannon in the room, who is my good friend, I respect her immensely, she would tell you that it's 2B on the NCCN, which is hard to get reimbursed, but she would try and use it for her patients because it is better. And I respect that. I am the co-PI of the study, and I don't actually believe that. I don't know that it meaningfully changes outcomes for patients and doesn't cure anyone, and we need to be really cautious about over-treatment. And so I just don't know that there's a future for PARP and endometrial.
Other thoughts on that? Before we have 1 minute left. Rob and then Dave.
So I think that I think there may be something there, because I think it's very interesting if you look at the PMMR cohort, the shape of those curves. They do separate which suggests to me that there may be something there. I don't think we know how to assess homologous recombination deficiency in endometrial cancer.
Well, no, I mean everything we tested.
And so I think that the story could be better written once we learn about functional assessments of HRD.
Dave.
Practitioners around the world love that regimen and are using it a ton. We do not. I do not. But we do have rare patients that will have BRCA mutations, RAD51C or D. In that situation, I will consider and have a discussion with them and then try to get paid for, which is extremely challenging.
But they didn't look any different on DOE.
That's the interesting thing, yeah.
Well, but when they lumped it all together with again not factors in the bracket, such small numbers.
So small numbers.
Yeah.
It may have been monoallelic. Like we don't really know.
Correct.
I don't know. I just think I think it's not wrong at all. And
Right.
if you can get it and your patient's well counseled, I don't think it's wrong. I am worried a little bit about, because it's not curative, and they're going to get an ADC, and then they're going to get a check 1-2, and then they're going to get something else. And how does all that stack up for a patient?
That apart.
It's not a transformative improvement in PFS. I just wonder about the marginal gains versus what the cost is to the patient. But I definitely don't think it's wrong.
Thanks for all the comments.
Thank you.
We're done on time.
Thanks, Dr. Thanks, So congratulations to you and the audience for doing these sorts of studies. And Brian and Katie, thank you for your leadership, but we have a lot of work to do. So let's move on now to part 3, cervical cancer care, new regimens and innovative treatment approaches. It's my pleasure to welcome Drs. Leslie Randall and Dr. Bob Napothuri. Dr. Randall will lead us off. Let's go, Leslie.
Great, let's go. Let's go. Ravens have a new coach, let's go. Okay. Hi, everyone. We've had not quite as much going on in cervical cancer, but we had a flurry of activity for the past few years. So I think we're all at a point where we can start digesting all of this data. The state of the science in the locally advanced space currently is to incorporate either immunotherapy or neoadjuvant or induction chemotherapy with chemoradiotherapy. We know that this came on a 25-year drought of a lot of trying, but no success in this space. So these were transformative studies. Cala almost made it with Durva, and then A18 and then interlace, as you know. So questions for the group. I'm going to ask my questions as we go. I'm going to start with Ramos. Has this data changed your practice, and how are you guys incorporating this at your site?
We have utilized the Keynote A18 regimen in clinical practice. We have not yet incorporated an interlace strategy, but the caveat is that my dear friend and colleague, Dr. Jyoti Mahadev, is the PI of NRG GY037. You got, yes, you set it up, which is an interlace plus, which brings in the A18 regimen, and we have that study open and are excited to enroll patients onto it.
But,
Yeah.
But globally, interlace is like
Hot.
Yeah.
Very.
It's very prevalent.
Yeah, so I'll go back here. I mean, interlace is very hot globally because it's accessible, right? And Pembro is not necessarily accessible in many places. And so there's also, it's also restricted in the US by stage. And we had the EVOLVE study. EVOLVE Cervical is a very important trial of a PD-1 CTLA-4 bispecific that is ongoing. We couldn't run that in the US because of the uptake of Pembro and because of the use of interlace. They're having some trouble in some other countries with the use of interlace. That trial doesn't allow. But there are many places in the world where that trial is occurring very well. So that will continue to be an important study. Yeah.
Let me interrupt for just a second.
course.
I want to recognize our Korean colleagues who've come here a great distance, so thank you for being here with us. And I guess what I was asking is, do you use interlace in Korea, or what do you do with the locally advanced cervical cancer patients?
Go back a slide.
Microphone?
You want to go to the mic, or do we have a handheld mic? Or? Just wait 1 second.
It's worth the wait.
Go back a slide.
You guys treat a lot of
Go
cervical
back a
cancer.
slide.
You're
Okay,
experts.
go back
Go
one
back a
slide.
slide.
Yeah, got it. Here we go.
There you go.
Great. Thank you for great questions. We can use the interlace trial in Korea, but the reimbursement is not permitted, not yet.
Oh,
Wow.
It is some barrier to us.
okay, thank you.
It's interesting. So it really varies globally, and as we know, cervical cancer is a global disease and very relevant. So here in the U.S., there's a lot of like, which one do we do? Do we do interlace? Do we do A18? So this is the trial that Dr. Mahadev is leading in the NRG that is looking to incorporate both these regimens and compare so that we can get some data on how this fares in practice. So here we are in first-line recurrent metastatic cervical cancer. So Keynote 826 changed how we treat cervical cancer. This is the GOG 240 regimen with or without pembrolizumab. And then the BEAT-CC regimen is the same with or without atezolizumab. And the key differences between the two studies are that 826 allowed physician's choice bevacizumab and BEAT-CC mandated Bev, although it had some strict criteria of who was a candidate for Bev. And that had to do with avoiding fistula with rectovaginal nodularity. So they were somewhat selected. So what's new in the data is trying to look at some subgroups. And we know that the intent to treat PFS hazard ratios were positive, as were the overall survival. But looking in the middle here, the PD-L1 positive, you can see the hazard ratios here, and the Bev treated. There appears to be a benefit in both PD-L1 positive and Bev treated. But if you look closer at PD-L1, both studies have pulled out PD-L1 positive and negative groups, and the 826 hasn't yet reported a hazard ratio. These are small groups, and there's only 11% PD-L1 negative patients in 826. BEAT-CC had a higher proportion, 29.7% negative PD-L1. It had a hazard ratio in that group of 0.48. So what in the heck does this mean? So I want to ask the group, I mean, does PD-L1 really matter for cervical cancer? Is it the way we're assessing the biomarker? Historically, we were looking at TPS with atezo and CPS with pembrolizumab, but here in BEAT-CC, they actually used the CPS, which was nice because you can sort of better compare those two in that situation. But these data in terms of prevalence of positive, negative, and hazard ratio are a little bit inconsistent. So, Brian, what do you make of that?
Yeah, it's a good question. I don't make much of it. I'd like
I should have asked someone else. I should have asked someone else.
You know, I like the 826 regimen, to be honest. I use it mostly. And my patients do well on it. As far as, I think most of these patients are PD-L1 positive. If I'm not asked about it, I don't, supply it for insurance reimbursement. And I'm not, maybe I'm just keeping it too simple, but it works.
Great, thanks. Katie, you just presented biomarkers. What do you think about this sole cervical cancer biomarker?
I mean, the PD-L1 story has just been very complicated, and we've learned a ton from the lung cancer data. Like, look at every study that's come out in lung cancer. The assay matters, the pre-analytic conditions of the tumor, which is really probably even more critical in cervix than it is in lung, where they're getting like a proximal biopsy or resection that it's going, we're like getting whatever nubbin of Tischler biopsy you took, 5 years ago or whatever, and then sending it and being surprised when the PD-L1 is uncertain. So the pre-analytic factors, I think, in cervix are very important. How it's processed and the assays and the different scoring. It's just lung has so many more patients that they've been able to work this out and figure out what their correct scoring algorithm and tumor handling criteria should be. We just don't have enough people. And remember, a lot of our people who participated in these trials were from other countries where, in some parts outside the US, the patients own their tumor. Like, they have their tumor.
Right.
And
I
so
think
we don't
that they should have that in the U.S.
Yeah, like it's like in a bottle in their garage. And so
I don't know if
In a
that
jar.
helps.
and so that doesn't help. So it doesn't help anything. It's a true story. So the cervix PD-L1 story is just, I think, just very consistent with the biomarker confusion of PD-L1 testing in many other tumors. And we just are probably never going to really solve it because of numbers and experience. And that's just
Exactly.
what I would say.
So, I love that you brought up pre-analytic, because that was a big difference between these two trials, is how it was collected and when it was analyzed. So with 826, it was analyzed very early on. There was little chance for antigen degradation. And with the BEAT-CC, these were shipped in globally all over. It was an IIT study. The sites were handling the tissue, and I'm not sure what the quality control measures were here. They had a great effort, but these were sent way after the fact. And so that may have played a big role here. So, I've been seeing patients for second-line trial who have been treated with the atezo regimen because they are PD-L1 negative. And it is NCCN Category 1 listed as an option for those PD-L1 negative patients. The FDA does not believe that yet. So moving on is, where are we going in this space? I'm jumping the shark a little bit on TROP2 ADCs and cervical cancer, because Bhavana is going to talk about why we're looking at this in the front line. But this is a study of sacituzumab tirumotecan with or without pembrolizumab, or with or without bevacizumab. So you can think of this as a Keynote 826 replacement. This is the Part 1 safety run-in. Brian Slomovitz is leading this trial globally and here in the United States. So in the safety lead-in, patients who've already started on the 826 regimen can go on study to get the combination as a maintenance therapy. And this is going to take 20 patients. And I guess we were talking before we started, Brian, you're saying it's going to open and close so quickly with only 20 patients that patients who haven't started chemo yet can't go on. But I guess these are our patients who've already started treatment that we need to be thinking about for this. It's open in 2 places in the U.S. Destin Black and Brian have it open.
Yeah, I don't want to. Yeah, the key here is it's a small Part 1 safety lead, and it's 20 patients. So we need your sites to open. We're excited about it. It's looking at kind of overall 5 drugs, which is, these patients are, for lack of a better term, durable. They're going to, we need a better option for them, because a lot of them are young and healthy. Otherwise, 826 is great, but we're looking to do better. So short lead in, and then we'll go right to the
panic button with 5 drugs. It is 5 drugs, but it's chemo induction, right? And then it's 2 or 3. in the maintenance phase. And then you're just extending out that response, trying to make that durable. And we've seen in the survival of 826, I mean, we've made this very durable, especially with Bev, and we've extended median overall survival times up to 3 years. And the patient that walks into the emergency room with liver metastases who got told by the ER doctor that she needs to go on hospice and comes to your office next week. So, I mean, that's not unusual, and I know that all of you have experienced that in your practices. So if you don't get the patient in quickly, where they definitely get the SAC-TMT in the maintenance phase, then they'll go, this is the actual randomized trial, and at this phase, they'll have to be randomized to pembro maintenance with or without the sacituzumab deruxtecan. So we are extremely excited about this study, and we're very excited that there's an continuing investment in cervical cancer, and we have a lot of sponsors in the room, so I would just challenge everyone to continue to prioritize cervical cancer. You saw the onslaught of treatments coming for ovarian and for endometrial cancer, and we're gonna have the problem of trying to juggle all these, but still not have enough options for our cervical cancer patients. So I'm gonna hand it over to Bhavana. Thank you. Thanks, guys.
Thank you.
All right, thank you, Leslie. So I wanted to just focus on recurrent cervical cancer and the role of ADCs. So we all know tisotumab vedotin was FDA approved with our phase 3 trial. And I'm going to just highlight these 2 other abstracts that were presented at ESMO with saci-termatican and saci-govatican. So I guess I'd like to just ask the panel, how are you treating your patients after IO?
Yeah. I mean, the way I look at it different. I mean, it's the same way, but the TV301 trial that we participated in and led to the FDA approval, we compared it from TV versus chemo, and the joke was we were really comparing TV versus placebo. Because chemo doesn't work for this disease. So I don't think, very rarely do we have an option in a recurrent setting. But truthfully, in those patients that fail IO that you're alluding to, I mean, TV is really a go-to option. And it's interesting that people will forget about with TV. The data were released on the Monday. 3 days before, on Friday, 826 was released. So in the matter of 3 days, it changed from a third-line drug to a second-line drug without doing anything. So it's but I think it's a go-to. And
what about TDXD, and how are you incorporating that with the FDA approval in 3+?
I think the question in context of what's available for therapy, the beauty of the design of the SAC-TMT trial is that the physician's choice chemotherapy arm affords you an opportunity to use tisotumab vedotin, which is what we believe to be the most effective standard. And that's also the beauty of having a robust enrollment in the United States, where we have tisotumab vedotin that we can use in these patient populations. And then secondly, to your point, HER2 3+ in cervix is not common. To me, it's kind of like the diamond in the rough. When you find it, it's a blessing. You can use it, which I have been fortunate enough to have a patient or two. But the beauty of the trial, that's why I love having that opportunity and available.
And we have to do better. I mean, we're all excited about 18% response rate.
Yeah, right.
Right? Now, we see disease control better, and we do see stability of disease. But by RECIST response rate, we didn't even see 18%. So having options like SAC-TMT, like other agents that are coming into space, are so important. Yeah. We have to enroll them to the United States. If we don't enroll enough patients in the United States, we may not have that option because the regulatory agency.
Not get approved. That's right.
And TV is a great option. Make sure you get on trial, so if they get randomized standard of care, you can get them TV.
Great points.
Great, and we're putting patients on. Oh, you're going to get to the. Do you have a slide for the trial?
Yeah, I do.
Okay, we'll wait for the trial slide.
So I also wanted to just delve into, as we have these new ADCs, thinking about target expression, and this study was presented at ESMO, and it looked at TROP2, tissue factor, and Nectin-4. And on the left, this was in over 500 patients, primary tumors, and you see here that TROP2 was expressed in about 70% of the high, tissue factor 50%, but Nectin-4 was only 12%. But then when you look at the recurrent lesions on the right, you saw that the Nectin-4 actually increased about 35%. TROP2 and tissue factor remained consistent. So what does this mean to you guys? And is this important? And how can we utilize this data as we think about designing future trials?
These are highly relevant targets, right? And I think cervix becomes the afterthought. I've already been on my soapbox already once about it. But these are highly expressed, highly relevant targets. And, Ramesh, to your point, the HER2, you're gonna see that more often in your adenos, not so much in your squamous, so just not as common, not irrelevant, definitely relevant, but not as common as these will be.
I think the landscape will continue to evolve as these move, just like we
Earlier
talked about
line.
earlier
Yeah.
with the ovarian cancer. It's
That's
the
right.
same, it's a cut and paste. And I think that's what we're seeing here. It's wonderful, though, that we have, because we have identification of more targets, that we're having more development. Because that, as you know, we had nothing for years.
But that's the key, is we
Yeah.
need to develop it to these targets.
Yep. Right.
And then test for them and have options. So
Right.
I think as we look, like we talked about in ovary, having that series of potential targets to then make some very difficult decisions, which one do you prioritize, would be the hope in cervix cancer.
Yep.
So this was Scott Jordan's abstract that Dr. Randall wanted me to really highlight. And Leslie, why don't you tell us why?
Yeah.
Sure.
So
Yeah, this is a gear switch, right? Because we haven't really talked much about patient-reported outcomes tonight, except talking about them setting the inferiority margin, which is really novel. But, this is really important. I mean, if you all remember when tisotumab vedotin became available, there was such fear about the ocular toxicity and how it affect patient quality of life. And this is a global look at quality of life, and there are no ocular, measures in these subscales. But if you look across these subscales, I mean, patients these actually favor TV. And usually, typically, patient-reported data is more kind of like even in the middle. It's not decremental. This actually may show some actual benefit here. Interestingly, the only one that's off is one that's a little bit underpowered, and that's sexual vaginal functioning. You have to wonder if that may be from the bleeding that can occur with TV. It's curious, this data can't answer that. But I think this gives you a level of confidence that not only are you getting an OS benefit out of this therapy, you've got improved quality of life.
Yeah, no, I think it's really important because we all think that, having to do all the eye care and all of that is really going to reduce their quality of life, and I think it gives us this confidence. So I think, that brings us into the current trials, ADC trials that we have open in the GOG, and we have GOG 3116, which is the ocular assessment trial. So, and this is really important because it's really looking at ensuring that the ocular assessment schedule is appropriate, so we really need everyone's help to get this enrolled. In addition, we have GOG 3101, Dr. Solani's trial of SASI termatican, based on the preliminary data that I had showed you earlier, looking at this ADC in the second or third line. And the US enrollment was actually increased to 100 patients, so it's really critical that we have good representation, especially because we need to ensure that diverse patients are enrolled. So we really need to get this done, and would really encourage everyone to accrue. And Dr. Randall already discussed GOG 3123. And that brings us to IO combinations and bispecifics. And so where are we headed? So Dr. O'Malley, you presented at ESMO your balstilimab and zalfrillimab.
Balzal, baby.
Balzal.
So what do you think we could do with this, Dave?
I think the combination therapy, look at the Nivo-Ipi data, there's a potential opportunity here. Unfortunately, Rapids did not allow prior IO. So I think when you're looking at the current treatment strategy and development, but we did see marked activity in the PD-L1 negative population. So a group of patients where you can really apply that. But I want to go back to the PROs for a second. If we have symptomatic patients and we have effective regimens, patients feel better by controlling their disease and helping their symptoms.
Yeah.
So important for us to remember that the better and the more we can keep the disease away and shrink disease, it impacts PROs. And I think sometimes we forget that.
Yeah, great. And then I think, the other data that were all presented at ESMO, I think the bispecifics are really exciting. The cadonilimab, yeah.
Yeah, I was going to say, the thing that, again, getting back to what innovation is happening outside of our little tiny circle, these bispecifics and now trispecifics and agents that are being, the radiotheranostics that are coming, they're all being developed across multiple different tumor types, and they will apply here. So right now we're talking about PD-L1 and CTLA-4 is kind of low-hanging fruit, but as we move into the VEGF bispecifics with PD-L1, and then as I said, these trispecifics, and then of course the radioligand potential opportunities, this is going to come. So fortunately, there's a good pipeline, and we need to be aware of what we can pull into the clinical domain for our disease type.
Yeah, it's going to take some, advocating, convincing that this is, worth their return on investment. And it's not listed here because it's older data, but the SASI-Pembro combo from ESMO 2 years ago, which is, basis of Brian's trial, 60% response rate in patients who'd had previous treatment with PD-1 inhibitor. That's huge. That's a huge proof of concept in my mind that you can do this again. Cervical cancer immunologically is just a different disease type.
Agreed.
I was to add to what you were alluding to, Rob. There's also emerging data about antibody drug conjugates as very effective radiosensitizers.
Yeah, there you go.
So as we think about the evolution, we're wedded to cisplatin. Cisplatin's a drug that's been around for God knows how long.
Yeah.
Can we do better with curative intent concurrent radiation and chemotherapy? Because as Dr. Maedev alluded to earlier today, there's still a 30% failure rate for those patients. Let's salvage them. Let's protect them from recurring.
Plus, you're bringing them in weekly for fluids and whatnot. I mean, cisplatin's pretty toxic still. Yeah.
Great. And Dr. Monk, you want to talk about your data that you presented at ESMO with TV combinations and where we can bring that forth?
Yeah, we're going to have a hopefully simultaneous publication. Our journal, Gynecologic Oncology, has a simultaneous publication presentation. So those data are in preparation. Hopefully we can try that. We've never done that before. I don't think any of us have had a Gynecologic Oncology journal SGO presentation simultaneous. Certainly a scanner done it in the New England Journal. So, but doing it in Gynecologic Oncology is tough. Just kidding. So congratulations on that. But we'll have it mature data at SGO, and we had it there. The bottom line is the combination with Pembro and TV is made into the NCCN.
That's right. Yeah, I think that's why it's relevant.
So that's a big deal. TV Carbo with Bev and Pembro, which is what will be at the SGO, what we call RMH, it also looks pretty good. Again, in what was been said to get rid of paclitaxel, replace it with TV.
That's right.
It just doesn't look good enough for someone to invest what it takes to get FDA approval. And you got Dr. Slomovitz, on the heels of his wonderful study with SAC-TMT in this space. So we're excited about it. It is what it is. It gives more options.
Great, thank you.
I thought that second-line TV Pembro was going to be irrelevant because prior IO, it moved to the front line, everybody's pretreated, but after that SAC combo data, I felt totally differently about it.
Yep.
Check it, use it. Yeah.
Wonderful.
Great.
Great.
All right.
Thank you.
All right, one final plea for at least one question from the audience, please. We're going to put the mic next time by the where we're serving adult refreshments.
There we go.
There we go.
Okay, for endometrial cancer.
Can you identify yourself first? That'd be great.
Josh Cohen, City Hope. How you doing?
Thank you.
Good to see you guys.
Good to see you, Josh.
For endometrial cancer, we talked about brachytherapy briefly with the Portex series. I'm just curious from your experience, the Portec 3 regimen, chemo radiation plus chemo, that's out there. We didn't really talk about EBRT. Are we just moving away from radiation completely for endometrial cancer except for vaginal cuff brachytherapy? What are your thoughts?
Hopefully.
Yeah, and I will say there's been a dramatic reduction in the use of external beam radiation at my institution. I know there's heterogeneity nationally, and ex-US, there's still a preponderance for use because B21, 75% of those patients, I believe, had external beam radiation, around 70%. But I think there's definitely a trend towards reduction, Brian.
Yeah, the inconsistencies that you're alluding to is why in B21 and in 3122 we allow for either. Because there are strong camps that feel they need radiation, there's strong camps that feel they don't. It's an old statement to say it doesn't change the survival curves, which we know it doesn't. Personally, I like to radiate when there's a target to radiate. Then I think it's effective and you really can see a difference and it's meaningful. But to give a whole pan field radiation when you're treating based on a risk factor is something that personally I've gone away from. It sounds like some others have as well.
Oh, yeah. But our radiation oncologists, if we send them for vaginal cuff, they often get counseled about whole pelvic radiation. And you're not there to weigh in. I mean, and I said, well, did you counsel about chemotherapy, right? Yeah. So I think as you look at that, is there a role and are there a group of patients who will benefit? We know we can help local regional control with no impact on OS. So how much does the local regional control impact to keep them from having a recurrence? But the problem is the whole pelvic radiation, long-term toxicities, so marked in our patients. That it's very challenging.
I think it was more important before we had really good SBRT, and now that you have really good SBRT, it used to be meaningful to prevent a sidewall recurrence because it was so miserable and so difficult to treat, but now you can SBRT that, or you have more effective systemic therapy.
And I also do more CAT scans in that higher risk group, so I catch the lesions smaller and they're not coming in with very symptomatic or visceral involvement.
Yeah, it used to be that a local recurrence was a very difficult situation to deal with.
Still is not. It's still difficult.
I mean, Josh, Portec 3, as you know, had the wrong control arm.
Yeah.
So if you have positive node in endometrial cancer, you're supposed to give chemotherapy, not radiotherapy. So Portec 3 was a randomized phase 3 trial of chemoradiation versus radiation. There should have been a chemotherapy alone arm, which is what we generally do. So it really is a radiation oncology interpretation paper. It's not a paper generally that we as gynecologic oncologists integrate. We do 258, we do other things.
But who doesn't remember when Daniela Mataya presented 258 and in all caps, was speaking in all caps, and basically said there were no subgroups who benefited from the addition of radiation in the chemo setting.
Yeah, and I'm not really sure if it's true or not. I say, I don't know if it's true, that the reason it got into the New England Journal is to teach people not to use radiation, and it didn't do that.
I think no, 75% in B21, it didn't happen.
Yeah. I hear you. I would say I agree with Dr. O'Malley, though, in that, a lot of the counseling happens with radiation oncology, too. And so they interpret things, and if there are any radiation oncologists here, very differently. Right. I would love for you guys maybe at the next GOG highlight reel, get a radiation oncologist up here to talk a little bit about it with you.
Deal.
Because I think it would be a good back and forth.
Great idea. I love it.
Back to the future.
If we recruit the right radiation oncologist, there won't be much back and forth. That's it.
Dr. Chan.
More than one.
Thank you for hosting us in your beautiful city, Dr. Chan.
I love her.
Hey, thank you so much for having me. I appreciate it. So, I'm a village doctor now in San Francisco. So I want to ask, I love the trials, and I love the fact that we have so many options for all our patients. But on Monday morning, I got to figure out how to treat these patients. So when I'm sitting in front of a patient, let's just give 3 patients here, okay? Patient A with ovarian cancer. Can I just ask the panel, raise your hand. On Monday morning, when I have a platinum-resistant ovarian cancer who's FR receptor alpha positive, do I do B96 or do I do Mirasol?
FR alpha positive?
Yeah.
75 or greater?
So 75 or greater, how many of you do Mirasol?
Right now, it's only approved.
How many of you do B96?
I mean,
I do it, but I do it after.
Yeah, we do it.
I do it after.
Okay. Sequencing is fine. Now I know what to do on Monday morning.
There's a narrative, right?
Listen, when you get a high folate receptor alpha,
Come on, man, you can't
I
say
get
it.
excited.
Yeah, you gotta
take
go.
Okay,
advantage of it.
okay.
John,
I gotta go.
we have a trial. We have a trial that in the comparator arm, we are looking versus Merv. Right?
Okay.
So get her on clinical trial, and I know you have a lot more clinical trials than you had a few years ago.
All right.
Next.
Village doctor number 2 seeing patient B with uterine cancer. She's got a node positive disease, totally resected, stage 3 uterine cancer. How many of y'all are put her on Pembro or
MMR.
GY?
MMR status.
Oh, no, PMMR. DMMR, I get it.
No.
Okay, we're talking PMMR here.
God, no.
70% of the patients. How many of you will put her on the Startlemab versus Pembro versus, Brian's B21?
Node positive PMMR.
Completely resected.
Completely
No gross
resected.
residual.
Yeah.
No measurable disease.
Yeah.
We actually saw harm
Yeah.
in those patients.
Wait, raise your hand.
I thought
Just vote
my
first.
interpretation.
Vote
My
first,
interpretation.
No,
My
no.
interpretation of that is that
It's a
could be
negative trial.
harmful if I do it
One
now.
person at a time.
It's a negative trial. The hazard ratio in the node positive, by the way, in B21, that was PMMR, was 0.82. So we should know. The 1.20 was in the ITT. But I think to answer your question,
Yes.
completely
Please answer
resected.
my
I will
question.
not give.
Wait. Can we just vote?
PMMR.
So this is
PMMR,
based
not
on.
ITT.
Hold on.
PMMR.
Yes.
This is based
How
on
many of
B21.
y'all would just still give immunotherapy based on NCCN guidelines and FDA?
No.
In the
Completely resected PMMR node
There's
positive.
FDA approval, though.
But he's asking, would you use it in practice on Monday? No.
So let me bring everybody to the same conversation. So the FDA approval,
The Startlemab approval.
Ramez.
Everybody.
So the FDA approval is advanced and recurrent. So Dr. Chan says this is an advanced patient. Was this patient eligible for GY018 or Ruby? No. Was it studied in B21? Yes.
He's asking what I would do.
I know, and so raise your
said
hand.
no.
Would you give that patient IO?
No.
3C1 PMMR?
No, completely resected. No.
Yeah,
Negative scan.
not one person.
So you would go against NCCN guidelines?
The NCCN guidelines are not well stated.
They're not granular.
I don't know what advanced means.
Okay.
So,
Right.
I think personally, I try to follow the eligibility for the clinical trial, not the ambiguity that some person, that's on the NCCN.
Got it. All right. Last question. The last question. I got a patient with advanced cervical cancer. Do I do interlace? Do I do, A08 keynote 8?
18.
Or do I do both?
Put her on trial.
Put her on the trial.
She doesn't want a trial. This is
Why?
Monday morning
It's
village
because are you
doctor,
counselor
man.
problem?
037.
Come on.
Wait, and
help
when you
me
say
out.
when you
Help
say
me out.
advanced, can you clarify for us, John, a little bit? What do you mean metastatic disease? Or you mean locally advanced disease?
Well, a person that would have fit interlace or fit the keynote study.
Yeah.
So if you do
What would you do?
locally-
Would you do a combination of both, or would you do one or the other?
Yeah.
Just,
Go ahead, Brian.
In my mind, A18
On Monday
was more
morning, what do I
rigorous.
do?
I choose A18.
I do too.
Brian.
Right.
A18.
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 18.
So it's easy to say.
Nobody would do both.
No,
Not now.
People do both.
Let Brian.
sorry.
Sorry.
I mean, I think the go-to answer is A18. It's the right answer. But remember, cervical cancer patients oftentimes they're in a different socioeconomic status. They have different types of coverages. So I've used interlace in a patient who can't get right into a radiation oncologist or who I can't get a PET scan for, and I give it comfortably, knowing that I'm giving something based on evidence-based data.
Thank you, Villa.
Thank you, Dr. Chan.
Thank you, John.
All right. All right. Well, thank you. This starts wrapping up our presentation and discussion for tonight's highlight reel. Thanks to all our panelists. You did an outstanding job. It wasn't until you got really tired at the end that you started talking over each other. So it was a really good job. I'm really proud of you. That was awesome.
Pulled it out. He made us go.
Yeah. Thank you.
all of it.
To our supporters, thank you for the independent medical education support associated with the symposium. AbbVie, AstraZeneca, BioNTech, Corcept Therapeutics, ASI, GSK, Karyopharm Therapeutics, Merck, Natera, and Verastem. GOG Foundation, Inc. would also like to thank our sponsors for the symposium, Gilead and Faith Therapeutics. Please complete your online evaluation, which will be sent to you via email. This particular session is worth up to 2.5 CME credits. In order to receive your credits, you must fill out the evaluation. Feedback helps the GOG evaluate the success of this program to develop content for future events based on your needs, and it's an iterative process. We need your feedback to continue to get better, so please give us your feedback, honest feedback. This program will be available on the GOG website at gog.org and on the GOG YouTube channel as enduring educational content. You can also find more about the GOG Foundation educational offerings on our social media platforms as well. Please follow us on X, Facebook, LinkedIn, and Instagram.
And most importantly, we want to thank you.
Yeah.
So none of this is possible without you, okay? These people can design all these trials, can write all these papers and talk, but it's when the rubber hits the pavement, when you put patients on clinical trials. And thank you to Dr. Herzog for being our president and leading by example.
Thank you.
And any closing comments by anybody?
We're not done yet.
Okay.
Yeah, a little bit. So, yeah, I also wanted to thank the audience. That was my final thing, to thank the audience. But for all of you for coming and giving up Friday evening in San Francisco, there are other things to do in the city, and we recognize that. So we thank you for sharing your time with us. We also look forward to our next highlight reel, and that'll be taking place at our Energy semi-annual meeting in Denver in July 16th to the 18th. We'll work out the logistics, and that'll be available on our website. Again, thank you. We're going to leave the refreshments open in the back so we can mingle a little bit. And thank you for being here, and thanks to all of you. Thanks. Thanks, Brad, for co-hosting.